OCD, Background, Solutions, and Symptoms for Patients. Written by Sid Van Roy. Narrated by Doug Green. Chapter 1. An Intro to Obsessive Compulsive Disorder. Obsessive Compulsive Disorder is generally regarded as a neurotic disorder like phobias and anxiety states. Other terms used for this disorder include obsessive or obsessional compulsive neurosis and obsessive or obsessional compulsive illness, or simply obsessive or obsessional disorder or compulsive disorder. Those with this problem can suffer significant distress and often feel that they are defenseless victims. Though unstable disorders are normally considered to be less handicapping and disabling than psychotic illnesses like schizophrenia, extreme obsessive compulsive disorder sometimes causes significant incapacitation and dramatically affects individuals' lives. Maybe a quick note is needed about the terms unstable disorder and psychotic disorder. Broadly speaking, neurotic conditions or neuroses are reasonably small psychiatric diseases. The unstable patient knows that he has an issue, that is, he has an insight. His contact with the outside world is relatively undamaged. On the other hand, psychotic conditions, or psychoses, are more serious mental disorders. The psychotic patient could have no insight that something is wrong with him, and his contact with the outside world might be significantly impaired. In the current psychiatric thinking patterns, obsessive-compulsive disorder is categorized as an anxiety disorder. Other anxiety disorders include phobias, panic disorder, and generalized anxiety. They all share anxiety as a fundamental function, and there is an overlap of symptoms amongst them. What is meant when a person is referred to as having an obsessive-compulsive disorder? The person displays and/or suffers either fixations or compulsions or both, to a degree that impacts his daily functioning or triggers him distress. Psychiatric analysis of the condition is generally made on this basis. This is shown in the generally agreed diagnostic criteria. 1. The person must have either obsessions or compulsions or both. A. Obsessions are persistent ideas, thoughts, images, or impulses that horn in awareness and are experienced as ridiculous or repugnant. They form against someone's will, and the person tries to withstand them or get rid of them. The person recognizes that they are his own ideas, and so on. B. The compulsions are recurring, purposeful forms of behavior that are carried out because of a strong feeling of compulsion to do so, and are normally performed according to certain rules or in a stereotyped style. The behavior is not an end in itself, but is focused on producing or stopping some event or circumstance. Nevertheless, the activity isn't connected in a sensible way with what it is aimed to produce or stop, or it is plainly excessive. The person generally recognizes the senselessness of the behavior and does not get any pleasure from carrying out the activity, though it offers relief from tension. 2. They are not as a result of another disorder, like schizophrenia, sadness, or organic mental illness. 3. The fixations and/or compulsions cause distress to the person and/or interfere with his life and activities. Chapter 2. The nature of obsessions. Actually, an obsession is an unwanted, invasive, persistent idea, image, or impulse. Obsessions are not willingly produced, but are experienced as events that attack a person's consciousness. They can be stressing, repugnant, blasphemous, obscene, ridiculous, or all of these. The person neither wants nor invites them. Instead, he typically resists them and tries to get rid of them. A fixation is a passive experience. It happens to the person. He may be participated in some activity, like reading a book or driving a vehicle, when the fixation horns in his awareness. It interrupts his normal thinking and behavior. Some examples of obsessions are as follows. 1. A young woman had the recurrent invasive idea that her husband would die in a car crash. She also had vivid visual images accompanying this idea. She would see the scene of the mishap, the two automobiles, the broken glass, the blood, and the hurt. 2. A young woman had the persistent invasive idea that she was contaminated by dirt and germs from complete strangers. 3. A guy had the reoccurring intrusive doubt that he could have knocked down someone crossing the road. 4. A young married woman had the frequent invasive impulse to strangle children and domestic animals. This would be followed by the thought or doubt that she might actually have done this. 5. A young man had the persistent invasive idea that Jesus was a jerk. He also felt an impulse to yell this out during prayer or a church service. 6. A boy had reoccurring intrusive pictures of himself violently assaulting with an axe his older parents. He also had the idea that he may actually commit this act. That experience included images of the victims, of blood flowing, and of injuries triggered. 7. A girl had the recurrent invasive impulse to harm herself by burning her eyes with a lighted cigarette. This was accompanied by visual images of the act. 8. A middle-aged man had the recurrent idea that he had cancer or would get cancer. 10. A 14-year-old girl had the persistent impulse to blurt out profanities in public. She also had the idea that she may actually do or have done this. Those examples show the highlights of a fascination. It horns in consciousness as an unwanted outsider. It could take the form of a thought, an image, an impulse, or a combination of these. Fixations in the form of ideas are far more common than those in the shape of impulses or images. When the fixation happens, the person typically resists it and tries to dismiss it. If he succeeds in dismissing it, it may well come back within a brief period of time. Some clients report that their obsessions are with them the majority of their waking hours, regardless of desperate battles to get rid of them. The effort involved in trying to suppress fixations can be tiring, even though the struggle isn't evident to good friends or loved ones. The patient doesn't regard the obsessional idea, image, or impulse as something stemming from outside. He recognizes and acknowledges that it is his own ideas. This is an important function, as in certain mental disorders, clients could experience thoughts having been taken into their heads by outside agents. Obsessions aren't experienced in this manner. It should also be noted that the meaning of the term obsession in the context of obsessive compulsive disorder is very different from how the word is often used in day-to-day language. We typically hear someone being described as obsessed with his job, and expressions such as, "he is obsessed with her," "football is an obsession for him," etc. What is meant in such circumstances is that the person in question has an unusually great interest in something or somebody, so that every little thing else pales into insignificance. However, such an attachment, interest, or preoccupation is not seen by him as undesirable or unacceptable, and there's no resistance or any effort to dismiss it. Nor is it something that keeps intruding episodically into the person's mind. This is extremely different from the way the term fixation is used in reference to obsessive compulsive disorder. Both senses relate to the meaning of the Latin verb obsidere, to besiege, from which the word fascination is obtained. What are fixations about? What are the contents of obsessions? There are some very common themes: contamination and dirt, disease and illness, death, violence and aggressiveness, harm and danger, and ethical and spiritual topics feature plainly among them. There are also sex-related obsessions and, less commonly, entirely ridiculous or insignificant ones. An example of one of the latter came from a man who experienced the frequent intrusive thought, "these boys when they were young." Woman had invasive visual pictures of asymmetrical objects and patterns she had seen, which would consistently come to her. In some cases, the fascination includes a doubting thought, which can apply to most things that the person does. Here is an example. A young woman complained that any time she performed any action, she would immediately be attacked by the idea, "did I do it right?" or Have I done the right thing? Chapter 3. Compulsions. A compulsion is a repetitive and apparently purposeful conduct that's performed according to certain guidelines or in a stereotyped fashion. It might be entirely inappropriate or, more often, partially acceptable. The behavior is not an end in itself, but is generally intended to produce or to prevent some event or circumstance. Still, the activity isn't linked in a sensible or reasonable way with what it is meant to achieve. For instance, touching a relative's photograph a certain number of times, so as to ensure that no damage comes to the relative. Or it may be plainly excessive, such as cleaning hands for half an hour at a time to get rid of germs. There are also instances where the person takes part in the compulsive act simply to fend off great anxiety and even panic. The act is preceded or joined by a sense of subjective compulsion. That is, the person feels a strong urge to take part in the behavior. Generally, there is a desire to resist. The person acknowledges the senselessness or irrationality of the behavior and doesn't derive any satisfaction from carrying it out, though it provides a release of stress or a feeling of relief in the short term. Some examples of those typical compulsions are as follows. 1. A girl repeatedly and extensively washed her hands to get rid of contamination by germs. The washing was done in a fancy routine, 6 times without soap and 6 times with soap on each occasion. 2. A young man checked door handles, gas taps, and electrical switches each time he passed by them. 3. A 15-year-old girl cleaned and washed the area around her bed, which includes the wall, each night before going to bed to rid it of germs and dirt. 4. A man opened letters he had written and sealed to make sure that he had written the correct things. Therefore, he would rip open the envelope, reread the letter, and put it into a new one several times before posting it. 5. Lady in her 40s complained that every time she went into a room, she had to touch the 4 corners of it, beginning with the left. 6. A boy had the strong urge to touch with the left hand anything he had touched with the right hand, and vice versa. 7. A young man had the compulsive urge to empty his bladder before each meal. Even if he had urinated a short while before, he would go and clear his bladder right before sitting down to a meal. He felt that otherwise he wouldn't have the ability to enjoy his meal. 8. A boy had the compulsion to look back over his shoulder at any structure that he was leaving. He would first look back over his left shoulder, then over his right, and then again over the left. 9. A girl had the compulsion to wipe with a damp fabric all tables and worktops, sometimes each time that she was to use them. She did this to get rid of what she called undetectable food particles. 10. A 35-year-old wife had the urge to wash and sanitize herself and her outfits out of fear of contracting cancer. She spent many hours each day doing this. The key function of all these examples is that the person feels a strong desire, a compulsive desire, to engage in a certain behavior, which he performs regardless of resistance and regardless of recognizing that it is irrational, or at least extreme. Covert compulsions. All the examples pointed out above are of obvious compulsive behavior, that is, conduct including physical actions, but some compulsions are concealed or mental. Sadly, a lot of writers on obsessive compulsive disorder and lots of medical professionals, psychologists, and psychiatrists tend to assume that compulsions are always overt behavior. They consider fixations to be mental events and compulsions to be overt motor events. That division is inaccurate. It's certainly true that fixations are psychological events, but not all compulsions are motor behavior. Many clients have concealed or psychological compulsions, which have all of the highlights of obvious compulsions and such. Here are some examples. 1. A man had the compulsive urge to say calmly a particular string of words whenever he heard or read of any catastrophe or mishap. 2. A middle-aged woman who was distressed by the intensive, recurring appearance in her consciousness of obscene words carried out a compulsive routine each time this happened. This included changing these words into comparable, acceptable ones. For example, well for hell, and saying them quietly 4 times. 3. A middle-aged man had the urge to imagine everything that was said in discussion to him and what he was going to say in reply. He would not reply until he had acquired these visual images. 4. Lady who was tormented by intrusive repetitions of bloody pictures of her relations and friends felt forced to reform those images with the people concerned in good health. 5. A young woman became really worried if she set her eyes on black items specifically before going to sleep. When this happened, she had the obsessional idea that it would trigger her to go blind or cause some other catastrophe. So, every time she experienced this, she felt compelled to imagine an item of a much different color, specifically white, as a way of preventing these ill effects. These examples should make it clear that compulsions aren't exclusively motor behavior but can be psychological acts as well. Covert compulsions are also described as cognitive rituals or cognitive compulsions. The active nature of compulsions. A feature of compulsions that needs to be worried here is that an obsession is actively brought about by the patient. He is not happy about doing it, but it is essentially his voluntary action, performed because of his compulsive desire and not an automated behavior. Therefore, it is different from tics and muscle spasms that are typically found in some people, specifically children, which are basically uncontrolled motor responses. Those aren't actively produced by the patient, making them different from compulsions. Resistance fixations and compulsions are usually resisted. At one time, it was considered by many specialists that resistance was an important feature of obsessive compulsive disorder. Still, we now know that this is not the case. Although in the huge majority of cases, the person does resist the fascination or the compulsive urge, there are many exceptions, specifically with regard to compulsions. It appears that in the early stages of the disorder, a patient withstands his compulsive urges strenuously, but after repeated failures over a period of time, he might start to show much less resistance. Patients with chronic obsessive-compulsive problems could experience little or no resistance to the fixations or the urges. Different, a determinant of the word compulsion. Just like the term fixation, our use of the term compulsion here is different from and more specific than the way it is used in everyday language. We usually hear people talking about compulsive lying, compulsive eating, compulsive gambling, and so on. Those kinds of conduct are different from the types of compulsions that we are concerned with here. As noted above, compulsions are acts which are the result of a desire that the person normally tries to resist, and which are carried out unwillingly. They are viewed as basically illogical or ridiculous, and give no satisfaction or fulfillment. Forms of conduct like compulsive betting do not show these features, although they are issues in their own right. They aren't part of obsessive-compulsive disorder. At times, the term compulsive is used for behavior like recurrent nail-biting, thumb-sucking, and hair-pulling. Those are routines, and the person generally participates in them, at least part of the time, without being aware of them. They lack the characteristic features of the compulsion in obsessive-compulsive disorder, like purposefulness and meaningfulness. True compulsions are carried out to achieve some aim. Conduct like nail-biting, hair-pulling, and so on is not. Nor do they provoke a feeling of resistance. Those types of behavior are best viewed as habits, rather than true compulsions, as their resemblance to the latter is superficial. Chapter 4. Biological Causes of OCD. The fact that OCD patients react well to specific medications affecting the neurotransmitter serotonin explains that the disorder has a neurobiological basis. Coexisting conditions like attention deficit disorder or autism can make OCD harder to identify and treat. The exact same is really true when a person with OCD struggles with sadness, substance abuse, or binge eating conditions. Signs of OCD are seen in association with some other neurological disorders. There is an increased rate of OCD in individuals with Tourette syndrome, a disease identified by involuntary movements and vocalizations. Private investigators are presently studying the hypothesis that a hereditary relationship exists between OCD and the tic disorders. Other diseases that might be connected to OCD are trichotillomania, the repeated desire to pull out scalp hair, eyelashes, eyebrows, or other body hair, body dysmorphic disorder, excessive preoccupation with imaginary or overstated defects in appearance, and hypochondriasis, the fear of having, in spite of medical examination and reassurance, a pretty serious illness. Researchers are investigating the place of OCD within a spectrum of conditions that might share certain biological or mental bases. A typical misconception is that people are rather compulsive or perfectionist by nature can be categorized as having OCD. Many individuals who show some compulsive or obsessive tendencies, which may be 90% of the population anyhow, do not really show severe enough symptoms to be labeled as having a disorder in this sense. Furthermore, try to see the value and contribution of being obsessed with a tidy or organized environment or the tendency to flawless things. How many firms could work without their exact accountants? How many cosmetic surgeons would do a great job if hygiene was not one of their most important standards? And how many people would feel comfortable in a space where absolutely nothing was tidied up or organized? Compulsive habits have their place in society, and some of them are highly needed. The problem with the ones who have OCD relies on the interference with important reasoning and crucial everyday jobs. Someone's story. Someone with OCD said, "As far back as I can remember, my family and friends referred to me as a worrywart. When I was all about the age of 16, my experiences with OCD began. I had just begun high school and things were stressful with all of the changes. A friend of mine had been affected with a case of food poisoning, and that was when I obtained my fear of being poisoned. I can still remember how it started as a small concern and proceeded to snowball into the major preoccupation of my life." Brain science. OCD is actually brought on by a combination of biological, mental, and ecological components. As far as the biological elements are concerned, an absence of serotonin, as I discussed earlier, is the primary cause. Serotonin sends neurological messages that transmit signals between brain cells. It contributes in mood control, impulse control, aggressiveness, hunger, sleep, pain, and body temperature level. For example, after a seat to the restroom, you might start to clean your hands to remove any harmful germs you might have come across. When you have performed the proper behavior, in this case cleaning your hands, the impulse from this brain circuit diminishes and you stop washing your hands and set about your day. It has been suggested that if you have OCD, your brain has difficulty switching off or ignoring impulses from this circuit. This in turn means the fixations and compulsions continue, leading you to wash your hands again and again. Studies concerning the numerous specific parts in the brain show that people with OCD show more typical activity in 4 interconnected areas in the brain. 1. The caudate nucleus. 2. Specific brain cells in the basal ganglia. 3. The prefrontal orbital cortex. 4. The cingulate gyrus. The first, the caudate nucleus, is considered to be the main part of the brain that controls repetitive and regular behaviors. Medication to treat OCD helps diminish the activity in this part of the brain. The last one, the basal ganglia, functions as a filter of thoughts getting in the center of the brain from other parts. The prefrontal orbital cortex, located in the front area of the brain, is believed to make reasonable decisions and affect social conduct. In the brain of a person with OCD, there's too much activity not having in this area. Usually, the case is that this region has been harmed just because of biological or psychological incidents and developments. A lack of guilt or responsibility is usually a symptom of somebody who is addicted and lacks activity in this part of the brain. The balance is off. The people who have become addicted either to pornography, compounds, eating, or betting have a smaller-sized frontal cortex with insufficient activity. In the brain of an addict, The frontal cortex is too little. Nevertheless, in the brain of a person with OCD, there's way too much brain activity in the frontal cortex. What does that mean? It means that they often be too worried, extremely concerned, preoccupied, or left feeling too guilty or afraid to act wrongly. The last one, the cingulate gyrus, is situated in the center of the brain, just like the basal ganglia. The cingulate gyrus contributes emotional responses to obsessive ideas. The emotions linked to the compulsive behaviors are usually what makes an OCD patient stuck in her or his patterns. This region of the brain is also highly interconnected with the prefrontal orbital cortex and the basal ganglia through numerous brain cell paths. All of these neurological paths and areas are highly affected by the levels of serotonin in the brain. Genetic causes. As with a lot of disorders, OCD seems to run in the family. Approximately 50% of all cases with OCD show this pattern. If somebody has a family history with this disorder, he or she is more likely to have it, and siblings, parents, or children. Research studies have fought the presumption that members of the family teach OCD to one another, based on the observation that individual family members normally have different signs of OCD. Scientists could not find specific genes that cause OCD, so in this sense, the genetic roots are still rather of a secret to a lot of clinicians. There has, though, been a ton of discoveries regarding the regulating of serotonin. Studies on twins have suggested that if one twin has OCD, the other has more of a propensity to have the same disorder. Nerve cells. The job of your afferent neuron is to send out messages and interconnected impulses, kind of like a telephone wire. Nevertheless, nerves aren't single string. The cells are all linked to one another. It's like the game of telephone, where a person whispers something in a person's ear, who whispers it to the next, and so on. Eventually, the message changes, and in some cases, it entirely differs from what the original message was supposed to be. This is how the brain works as well. The messages and impulses go through a series of procedures and regions which divert the original message and turn it into a somewhat different interpretation. How different that interpretation is depends upon the person, how well the cells work, and on how healthy and undamaged those neurotransmitters inside a person's skull are. One nerve cell sends a message to another, and that one sends out the message to another, and each time an afferent neuron gets a message, a chemical gets released. Usually, these substances are serotonin. A crucial gene in this process is hCERT, and this makes serotonin transporters. At times, when a person has OCD, the hCERT gene works too rapidly, which triggers the cell to gather all the serotonin before the next cell has even gotten the signal. OCD patients' nerves are whispering when they are supposed to be yelling. Another reason for the disorder, according to research, might be the membrane protein accountable for the reuptake of serotonin from the synapse between the nerve cells. That transporter protein is bound by serotonin inhibitors, or SSRIs, which block the transporter's function and leave more serotonin available for neuronal communication within the synapse. The scientists found a mutation inside the hCERT gene, which they classified I425V. The anomaly seems to be associated with an extended expression of the hCERT gene, leading to extra transporter proteins appearing inside the nerve cell's membrane. That results in accelerated reuptake of serotonin in those neuronal synapses, lowering the amount of serotonin available inside the synapse for signaling. The second anomaly identified, a long allele of the promoter part of the serotonin transporter gene, 5-HTTLPR, outcomes in equivalent cellular results, a boost in transporter proteins resulting in a decline in serotonin being available for neuronal discussion. The two anomalies performing together bring about an especially lower amount of serotonin available within the synapse than is visible with either one of the mutations alone, resulting in additional biochemical consequences and more extreme symptoms and signs. Other research has revealed that there can be some of other elements that would contribute inside the beginning of OCD, like behavioral, cognitive, and ecological elements. Research has discovered a terrific offer about the mental aspects that preserve OCD, which in turn has produced efficient psychological treatment within the shape of cognitive behavioral therapy, CBT. An example would be the following. According to the learning theory, OCD signs and symptoms are a result of a person developing learned negative ideas and behavior styles in the direction of previously impartial conditions which can result from life research studies. Many cognitive theorists really believe that the ones with OCD have malfunctioning beliefs, and that it is their misinterpretation of invasive ideas that causes OCD. According to the cognitive model of OCD, all of us experience intrusive thoughts from time to time. Even so, human entities with OCD frequently have an inflated experience of duty, and misread these ideas as being really essential and full size that could result in devastating outcomes. The repeated misconception of intrusive thoughts leads to the development of the obsessions, and because the thoughts are so distressing, the man or woman participates in compulsive behavior to try and withstand, block, or neutralize the obsessive thoughts. Several researchers trust that this concept questions the natural concept, as humans can be born with a natural predisposition to OCD but in no other way develop the full disorder, while others are born with the same predisposition but when subject to enough learning experiences develop OCD. Researchers have observed that another gene called SLC1A1 is most likely involved. This gene is similar to HSERT, but supervises of soaking up a completely different neurotransmitter described as glutamate. Psychological causes. So many mental theories have been delivered to give a clarification for the enhancement of OCD. The two that have received the greatest support are the behavior and cognitive theories. Chapter 5. The behavioral and cognitive theories. Behavioral theory. The behavior theory suggests that human beings with OCD associate certain things or circumstances with fear, and that they discover ways to stay away from the important things they worry about or to perform rituals that help lessen the concern. This pattern of stressing and avoidance ritual can also begin though people are under periods of excessive emotional pressure, together with beginning a brand new process or ending a relationship. At such times, we are more vulnerable to fear and tension. Typically, matters once regarded as neutral might also start to bring about feelings of concern. Here is an example. A person who has always had the ability to use public bathrooms may, when under pressure, make a connection between the restroom seat and a worry of catching an infection. Once a connection between a product and the sensation of concern becomes set up, human entities with OCD keep away from the matters they fear rather than face or tolerate the fear. For example, the person that fears catching an infection from public restrooms will keep away from using them. When forced to use a public bathroom, she or he will be able to perform troublesome cleaning rituals, which include cleaning the toilet seat, cleaning the door handles of the cubicle, or following a detailed washing process. As those actions quickly decrease the level of fear, the concern is never challenged and dealt with, and the behavior is enhanced. The association of worry could furthermore spread to other things. That includes public sinks and showers. In behavior therapy, individuals with OCD find ways to face and reduce their anxiety without working toward avoidance or ritual conduct. After they learn how to straight-face their fears, they be less afraid. Cognitive theory. While the behavioral concept concentrates on how humans with OCD make an association between an item and fear, the cognitive theory focuses on how people with OCD misread their thoughts. The majority of people have intrusive or unwelcome thoughts, just like the ones pronounced by way of human beings with OCD. As a circumstances, parents under pressure from looking after an infant can also have an intrusive notion of damaging the infant. Many people might be able to shake off this type of idea. Most people liable to developing OCD, however, might exaggerate the value of the idea and respond as if it represents a real hazard. They will think, I must be a threat to children if I have thoughts of hurting kids. This could trigger a high level of madness and other bad feelings, along with disgrace, guilt, and disgust. Those who come to fear their personal thoughts typically try to neutralize feelings that arise from their ideas. One way this is done is by means of keeping away from conditions that may stimulate such ideas. Another way is through carrying out rituals together with washing or hoping. Cognitive concepts suggest that as long as people translate intrusive ideas as catastrophic and as long as they continue to really believe that such thinking holds truth, they could continue to be distressed and to exercise avoidance and/or ritual behaviors. In line with the cognitive theory, individuals who connect overstated risk to their thoughts do so because of fake ideal visions learned earlier in life. Researchers presume the following beliefs may be critical within the development and protection of obsessions. 1. Exaggerated responsibility, or the belief that one is responsible for stopping bad luck or damage to others. 2. The concept that positive ideas are extremely critical and should be managed. 3. The belief that somehow having an idea or an urge to do something will increase the possibilities that it will come to life. 4. The propensity to overestimate the likelihood of danger. 5. The perception that one must always be ideal and that mistakes are unacceptable. After I initially experienced my OCD, I thought I was losing my mind. I had by no means fretted about those ideas before, and now I was totally covered with them. I knew what I used to be feeling became unreasonable, but I still had this terrifying feeling of what if? What if it was at all feasible for this stuff to happen? I knew that the odds were 0.0001%, but I would still be overwhelmed with the worry that something dreadful would possibly strike me or somebody else. In cognitive treatment, people unlearn their incorrect beliefs and exchange their styles of thought. Through doing so, they have the ability to get rid of the anguish connected with such thoughts and to stop their compulsive habits. No person actually knows what different aspects might be concerned. Maybe an illness or maybe normal life tensions should lead to the activity of genes associated with the symptoms of OCD. Typically accepted inside the past, but nowadays increasingly more left out, the psychoanalytic theory shows that OCD develops just because of a person's fixation springing up from unconscious disputes or strong pain they experienced at the time of infancy or youth. This theory is now pretty appropriately neglected, just because of the failure of psychoanalytic treatment to deal with OCD. Significant stresses or irritating life activities could also precipitate the onset of OCD. Even so, those aren't thought to cause the OCD, but rather activate it in a person already inclined to the disorder. Sadness is also once in a while thought to cause OCD, in spite of the simple fact that the general opinion is split, with most experts believing that depression is normally a sign of OCD instead of a cause. There is, however, a great deal of theoretical contention surrounding the definitive cause of OCD. However, all of the above theories offer engaging and highly helpful insights, with the possibility that a mix of the theories might also become identified as the real reason for OCD. Whilst the cause is currently still being debated, in some cases intensely by the researchers, what isn't always in competition is the reality that obsessive compulsive disorder is certainly a continual, but similarly a very treatable health condition. Chapter 6. Environment Causes of OCD. Ecological stress factors may be a cause for OCD in people. Let's have a look at some of these stress factors. Brain injuries in teens and children have also been connected to an increased risk of a continuing obsessive-compulsive disorder, with one research study finding that 30% of kids aged 6 to 18 who experienced a brain injury showed signs of OCD within 12 months of the damage. Normally, research suggests that sufferers with OCD often report traumatic and hard life circumstances before the disorder starts. Tension and parenting patterns are environmental elements that have been blamed for causing OCD, but no evidence is really there yet to that claim. Fine. These elements could add to the development of it, and the right environment for an OCD patient definitely figures out how strongly the signs appear. But to say that the environment or an individual's youth by itself are the main roots of obsessive compulsive disorder is a false notion that cannot be proved. Pressure doesn't trigger OCD, in spite of the fact that a distressing event may also activate its start. If left unattended, routine anxiety and pressure in an individual's life will intensify symptoms and signs of OCD. Problems at school or paintings, college exam pressures, and regular issues in relationships can bring all contributory elements to growing the frequency and intensity of someone's OCD behavior. Several children begin to display signs after a severe infection, which could be something like strep throat. The frame's natural reaction to infection, the production of sure antibodies, though directed to parts of the mind, could be related in some way to pediatric autoimmune neuropsychiatric problems related to streptococcal contamination, PANDAS. Research realized that the infection doesn't primarily trigger OCD, but it sets off signs and symptoms in children who are genetically inclined to the disorder. It is far idea that if OCD is caused by a kind of strep throat, the signs will start quickly, in all probability within a couple of weeks. Chapter 7. Some solutions. Now we're going to go over a few solutions. Left untreated, OCD generally develops into a persistent condition with episodes where symptoms appear to enhance. Treatment for OCD will depend upon how a lot the circumstances influence the patient's ability to operate. The best treatments. First-line treatments for OCD will regularly include 1. CBT, cognitive behavioral therapy. 2. SSRI, selective serotonin reuptake inhibitors. 3. Mix of SSRI plus CBT. 4. Cognitive behavioral therapy. CBT is an effective method of dealing with OCD. CBT is a sort of psychotherapy, talking treatment, that tries to help the patient change the manner they actually believe, feel, and behave, and refers to two incredible treatments: an exposure and reaction avoidance, ERP. B. Cognitive treatment. Research studies have revealed that 75% of human beings with OCD are considerably helped through cognitive behavior therapy. Exposure and response avoidance, ERP. Direct exposure. A part of this solution entails exposure to conditions and items that cause fear and anxiety. Over the years, the tension generated through those obsessional signals decreases, and subsequently the obsessional signals cause little or no anxiety. Response. Reaction avoidance describes the ritual habits that people with OCD have interaction in to minimize tension. This treatment makes it possible for patients learn how to face up to the urge to carry out those routines. Here are some tips for dealing with OCD, just to line them up. 1. Continually count on surprises. You can have an obsessive thought at any time or in any area. Do not be surprised if some new ones happen. Don't enable it disturb you. 2. Be inclined to just accept hazards. Danger is a part of life, and as such it can't be entirely gotten rid of or overlooked. Consider that not recuperating is the biggest hazard of all. 3. Do not lose time seeking to save yourself. This might only have the opposite effect and result in having even worse thoughts. Research studies have indicated that you cannot effectively prevent or reduce ideas, so accept that. However, a thought is a thought, absolutely nothing more. 4. Don't get restless with your progress. Don't compare yourself to other individuals. Everyone has their own pace. You can just concentrate on doing your treatment homework each day, one day at a time. 5. Face the anxiety. Don't hesitate and try to avert it. The best way to get rid of fear is to understand it is there. You can't switch off your ideas, so just face them. It is the only roadway to healing. Choose the harder one when challenged with 2 decisions. 6. Look at your homework from treatment every day. It's simple to overlook your tasks, specifically the ones you don't want to do. 7. Let your therapist know about tasks that are too hard for you. If you can't do it, then do not. You are not prepared yet, and that's fine. The homework they give you is not supposed to overwhelm you, but help you. 8. Don't postpone treatment. There is no flawless moment. The flawless moment is just when you start acting. Perfectionism is something you are trying to stay away from anyway, since it lies at the root of obsessive compulsive disorder. Don't be too hard on yourself and just do what you can. Don't do your homework so exceedingly that it takes too much time. Living life to the fullest is the purpose. So get rid of that one-track mind towards your objective for a little bit and enjoy the fun in your daily life. 9. Have faith in the homework you've been given. Do not brush it aside and only do it since you are asked to. If you don't trust your therapist, then what's the point? Appearance. These qualified professionals usually know exactly what they're doing and what you are supposed to do to get rid of or manage your disorder. So take their word for it and put your heart and soul into your projects. 10. It's all right to feel anxiety. After a while, it will decrease if you keep doing what you should be doing. So do not freak out about going crazy. Don't get mad since you're mad, and do not get stressed out as you are and you shouldn't be. I have been in those circles myself, and it's not worth it. 11. Don't forget that you still have OCD. That means you can't always trust your own emotions or reactions, because your brain has been wired to think in extremes. If you don't know for sure if something is a sign, then treat it as one. It's better to do a little more than insufficient. 12. Remember that compulsions are the problem, not anxiety. If you recognize this, you will stop the compulsions and stay with the fearful situation. Ultimately, the anxiety will go away as you boost your tolerance levels. 13. Reward yourself. It does not need to be a physical benefit. It can be just patting yourself on the back or be proud of yourself. Look back at the recent projects that are no longer difficult if you think you aren't making good enough development. 14. Bear in mind that OCD is paradoxical and doesn't always add up. It does not make sense what you feel all of the time. Some things appear even worse than they are, so do not go crazy and relax as much as you are very capable of. Medication, counseling, and treatment. Let's talk about some options to the disorder. First of all, let's continue with medicine, since I already pointed out some facts about this. Medicine. Corrective medications called particular serotonin retake-up inhibitors, SSRIs, are typically used to handle obsessive-compulsive disorder, though it is not totally perceived why the SSRI solutions appear to help a couple of individuals with OCD. There is a certain medication that withdraws OCD by gathering serotonin by means of transporters such as HSERT, which mentions that serotonin stays inside the range between the cells longer and increases the odds that the second versatile gets the message, which spare you some OCD signs and bad effects. Therapy. Medical trials just recently have shown that medications that impact the neurotransmitter serotonin can overall diminish the manifestations of OCD. The first of these serotonin retake-up inhibitors, SRIs, particularly verified for the usage in the treatment of OCD, was the tricyclic upper clomipramine and anafranil. It was routed by different SRIs that are called particular serotonin retake-up inhibitors, SSRIs. Those that have been verified by the Sustenance and Medication Organization for the treatment of OCD are citalopram, Celexa, fluoxetine, Prozac, fluvoxamine, Luvox, paroxetine, Paxil, and sertraline, Zoloft. Extensive evaluations have confirmed that more than 75 out of 100 clients are helped by these pharmaceuticals. What's more, in the majority of patients, solutions reduce bad side effects of OCD, by reducing the reoccurrence and power of the fixations and impulses. For clients who are just in part receptive to these medicines, research is being directed on the usage of a SRI as the necessary pharmaceutical and one of a selection of prescriptions as an extra medication, an augmenter. Drugs are of support in controlling the side effects of OCD. Conduct treatment. Psychological behavior treatment, CBT, has seemed the best sort of psychological therapy for this problem. The patient is presented to a scenario that activates the over-the-top signs and adapts step by step to endure the stress and fight the temptation to play out the impulse. Prescription and CBT together are thought to be superior to treatment alone at reducing side effects. Certain approaches demand that the patient deliberately stands up to the dreaded demonstration or idea, either particularly or by creative capability. In the meantime, the patient is unquestionably urged to forego ritualizing, with support and structure given by the professional and maybe by others whom the patient volunteers for help. Treatment then continues on a well-ordered premise, guided by the patient's capacity to endure the agitation and control the ceremonies. As treatment advances, most patients gradually encounter less anxiety from their excessive thought patterns and can oppose their impulsive dispositions. Psychotherapy can also be utilized to offer powerful approaches for lessening stress, tension, and settling inward clashes. Approaches to make treatment more effective. Stretch administration systems and consideration can help people with anxiety problems relax themselves, and so they might upgrade the impacts of treatment. There is evidence that vigorous practice may have a quieting impact. Since caffeine, certain illegal medications, and even some other pharmaceuticals can disrupt the signs of anxiety issues, they ought to be avoided them. To put it simply, do not do drugs or any medication the doctors haven't prescribed. And don't use caffeine. Talk to your medical professional or drug professional before taking any extra medications. Family. The family is vital in the recuperation of someone with an uneasiness issue. In an ideal world, the family ought to be strong but not help support their valued one's bad effects. Family members ought not to trivialize the chaos or request change without treatment. At the point when a relative experience happens, it works to be understanding about their advance and recognize any triumphs. When a family is encouraging of an individual with OCD and lionizes and empathy, clients will be less restless and better able to handle the results of their disorder. While this is obvious, reality shows that tons of relatives undervalue the impact they can have. This has been OCD. Background, Solutions, and Symptoms for Patients. Written by Sid Van Roy. Narrated by Doug Green. OCD, Obsessive Personalities and Disorders Explained. Written by Sid Van Roy. Narrated by Doug Green. Chapter 1. The Diagnosis. It's true that somebody might be considered as having an obsessive-compulsive disorder if he experiences or shows fixations or compulsions or both, though we added an essential qualification. It isn't the presence of fixations and or compulsions as such that matter, but the degree to which they cause distress and or interfere with the person's life. Obsessions and compulsive behavior. It is necessary to recognize that fixations and compulsions are not uncommon in the general population. There are many people who never go to a clinic or hospital looking for help, but who have fixations and or compulsions. Normal obsessions. Several research studies carried out in different centers have revealed that lots of people arbitrarily chosen from the general population, in simple fact about 4/5 of them, have fixations. Those are no different in either form or content from the fixations of patients who look for help. The distinctions are quantitative. The non-clients tend to have them less regularly. Their distress as a result of them is less extreme, etc. In a research study that was performed in London some years ago, we asked a random sample of people to report their fixations, if they had any. Here are some of the obsessions they defined. Thought of a mishap occurring to a loved one. Idea of harm befalling her children, specifically accidents. Thought that the chances of an air crash, including herself, would be lessened if one of her loved ones had such a mishap. The thought that she might commit suicide. Thought of unnatural sexual acts. Impulse to jump off the platform in front of an approaching train. Impulse to strongly assault and kill a pet dog. Impulse to do something, for example, shout or toss things to disrupt peace at a gathering. Thought that she and her husband and the child she was because of HAB would be significantly hurt because of exposure to asbestos. As can be seen, they are like the fixations commonly reported by obsessive-compulsive patients. Regular compulsions. Similarly, a big percentage of typical people have compulsions. Numerous forms of checking behavior are rather prevalent. Consider, for instance, a man who goes round the house checking to ensure that all gas taps are closed before leaving home, or a housewife who returns 1 or 2 times to the kitchen she has just left to make sure that the oven is turned off. No one would seriously consider them to have an obsessive-compulsive disorder needing help. Many people have minor compulsive routines, like always putting on the left shoe first, or setting up the desk in a particular way. Studies have revealed that such compulsions aren't uncommon in the general population. An excellent account of compulsion in a normal person is provided in Boswell's biography of Samuel Johnson, the great 18th century man of letters. Boswell commented on different singularities or particularities of Johnson. He had another particularity of which none of his friends ever ventured to ask an explanation. It appeared to be some superstitious habit which he had contracted early, and from which he had never ever called upon his reason to disentangle him. That was his anxious care to go out or in at a door or passage by a certain number of steps from a specific point, or at least so as that either his right or his left foot, I am not certain which, should continuously make the first real movement when he came close to the door or passage. Hence I conjecture, for I have on countless occasions observed him unexpectedly stop, and after that appear to count his steps with a deep earnestness, and when he had disregarded or gone wrong in this sort of magic movement, I have seen him go back again, put himself in a proper position to start the ceremony, and, having actually gone through it, break from his abstraction, walk quickly on, and join his companion. Superstitions. There are similarities between superstitious ideas and some obsessions, and between superstitious acts and compulsive behavior. Superstitions and certain fixations are comparable in that the person recognizes the irrationality of the idea or its associated activity, but prefers to err on the side of care or safety. Like compulsions, lots of superstitious acts are performed in order to prevent a bad luck from happening. Even so, there are also many superstitious acts that are performed in order to boost the possibility of good luck. This is never ever the case with compulsive behavior. Farther, fixations can be distinguished from most superstitious notions in that the content of the obsession is often unacceptable or repugnant, leads to resistance, and triggers distress. Fixations also have a personal quality, whereas superstitious notions have a tendency to be shared by many members of the community or family. Distress and disturbance. What makes a person a candidate for the diagnosis of obsessive-compulsive disorder? The key question that needs to be asked is, do the fixations and/or compulsions cause him distress or significantly impact his functioning? If the issues are serious, they will unquestionably cause much distress and will hinder his life. Experiencing an unwanted thought once a day typically could not possibly cause someone any real distress, but if it were to happen lots of times each hour, that would be traumatic. Likewise, checking all the gas taps 1 or 2 times before leaving home hardly disrupts someone's life, but if one were to check, say, 7 times on each occasion, then that would definitely interfere with an individual's normal performance. Some clients reach centers or health centers only after the issue has advanced to such a degree regarding have caused extreme effects on their lives. For instance, lady came for help only when her compulsions had developed to such a certain extent that she was spending all her waking hours cleaning the house. Another patient, a guy, had resigned from his job since he ended up being progressively worried about the germs that he thought would impact him through contact with others. At times, the person's obsessions and compulsions are more traumatic besides to himself. Consider, for instance, a guy who had an obsessional concern about germs and dirt, and who carried out washing and cleaning up rituals routinely. This may never ever have become an issue in itself, but he also started to firmly insist that his partner and mother-in-law did the same. If they refused, he would get extremely angry with them. He started eventually to insist that they both washed their hands at certain times, that they kept their towels in certain places, etc. The preliminary distress was hence felt not by him, but by others who were coping with him. In sum, the strong urge is a minor one which doesn't influence somebody's life or functioning typically, but can be an issue in certain circumstances. A young man had the compulsion to look at any stranger a second time if he observed somebody on the street who passed by him. He would immediately turn round and look at the person in question once again. That was a safe, if peculiar, compulsion, and stayed so until he got a sweetheart. The latter observed this behavior and immediately presumed that he was demonstrating an unhealthy interest in other women, despite the simple fact that he was looking at members of both sexes indiscriminately. The taking place disagreement very almost triggered the split of their relationship. It was this that brought him to a psychologist for guidance. Otherwise, he might never ever have felt any need to seek help. In another case, a guy was confronted by store detectives in a large grocery store. He confessed that he had acted in a way which might have given rise to suspicion. He had a compulsion to touch with one hand anything that he had touched with the other, even if he needed to turn round and return to the object to do so, and to make the hand in question completely free by transferring whatever he was carrying to his other hand. Till this humiliating event, he had not realized what a spectacle he was making from himself in public places. What can we conclude from all this? Both fixations and compulsions are pretty common amongst people in the general population, and they're not really considered as issues unless they trigger distress or interfere with somebody's life. If, however, somebody has fixations and/or compulsions that cause him distress or seriously affect his life and activities, then he may need guidance and help. It's this minority of people who get detected as patients with obsessive compulsive disorder. Chapter 2. Comparing Obsessions and Compulsions. Up till now, fixations and compulsions have been talked about as two separate phenomena. What about their relationship? In some of the examples of compulsions given above, a relationship between the two is plainly implied. We referred, for instance, to a young woman who had the invasive thought, fixation, that she may go blind whenever she saw black items, which caused her interesting in a compulsive psychological activity of visualizing items of different colors. The relationship between the two events in this case is clear. Fixation caused the urge. That is extremely common, certainly. We know that in the bulk of cases of obsessive compulsive disorder, obsessions and compulsions are related in this particular way. To show you a typical example, when somebody gets the obsessional idea that he may have mistakenly touched something that infected him, he's very likely to feel a strong compulsive urge to decontaminate himself by cleaning his hands a certain number of times. These compulsions are sometimes referred to as reducing the effects of behavior, as they serve the function of reducing the effects of, or putting right, the preceding obsession or its consequences. In a minority of cases, the obsession takes place by itself, that is, without leading to an obsession. Here is an example. A girl had frequent thoughts and pictures of her wedding reception, which had taken place over a year ago. These ideas generally centered on the flower arrangements, which she felt had been unacceptable. The ideas caused her pain, but there was no associated compulsion of any sort. There are also cases, even fewer in number, where an obsession happens without a preceding fixation, as in this example. A man had an obsession to imagine car registration plates in a certain way. Whenever he observed a car license number plate, he compulsively envisioned the same plate with a number transformed in particular ways, like squared, halved, or multiplied by 2. Elements of an obsession. One way to understand the relationship between fixations and compulsions is to consider all the elements that may be present in an obsessive-compulsive experience. Since we have talked about obsessions in some detail previously, we shall not linger on this here. Suffice it to note that there can be obsessive-compulsive experiences without a fixation as part of them, although this is unusual. A trigger, for example, seeing the walls of a room, may lead straight to a compulsive urge, for instance, to touch them in a particular order. Discomfort. The incident of the fixation typically leads to some feeling of pain. It may also less frequently be generated simply by exposure to the trigger or by the compulsive urge. For many, this feeling is best described as anxiety, but some clients report that what they feel isn't anxiety, but general uneasiness, stress, or perhaps a sense of guilt. Discomfort is therefore a much better term to use here, as it includes all these feelings. Keep in mind that Table 2 states that obsessive-compulsive experiences always include pain. This could, though, not be so for non-clinical cases. Compulsive urges. As noted above, this is the desire or drive that the person feels to carry out a specific behavior, normally in a certain way. As Table 2 shows, not each obsessive-compulsive experience has this component. Compulsive behavior. We have discussed this in detail earlier, so we shall not get stuck on it here. This is the behavior, obvious or covert, that arises from the compulsive urge. When the term compulsion is used, it normally refers to the compulsive urge and the compulsive behavior taken together. Pain reduction. When the compulsive behavior is performed in the needed manner, the patient normally feels relieved. The pain caused by the fascination and/or the trigger and/or compulsive urge is removed or reduced. There are circumstances, undoubtedly few in number, where performing the compulsive behavior does not cause discomfort decrease. Indeed, in a little number of cases, the pain may even increase. Fears of catastrophe. These are found relatively regularly. The patient feels that a particular disaster will happen unless he wards it off by participating in his compulsive behavior. An example would be the following. An elderly man had a very strong fear that if he didn't check the gas taps in his home a certain number of times, the home would blow up and go up in flames. The relationship between the particular catastrophe feared and the compulsive behavior is naturally not always sensible. For example, a boy felt that his hand-cleaning rituals stopped major accidents occurring to his relatives. Reassurance looking for. So many obsessive-compulsive clients turn to reassurance seeking, typically from members of their families. Often, obsessional ideas like, will I go crazy? Did I do it properly? And do I really need to check the taps again? Cause the patient asking for peace of mind. When a assurance is received, the patient feels some remedy for his discomfort. Peace of mind looking for is often done consistently, much to the exasperation of loved ones. Avoidance. This can be a substantial feature in the medical picture, though it is not part of the obsessive-compulsive experience itself. Generally, the avoidance behavior issues objects and situations that can potentially set off the obsession or compulsion. An example would be the following. The ones with fixations about dirt or germs and associated cleaning or cleaning rituals normally aim to stay away from what they believe to be filthy or polluting and those with checking rituals could keep away from situations that demand checking. Woman who had the obsessional thought that she might stab her kids went to great lengths to avoid contact with knives, scissors, and other sharp objects. A young man who feared that he may catch AIDS completely stayed away from certain areas of London. Sometimes it is not places or things that are stayed away from, but behavior. A patient might not wash in the morning, or at all, for several days, since this behavior needs a long and complicated routine. An outstanding example of avoidance of both items and behavior is as follows. A wife in her late 20s had the obsessional idea that she had cancer. After several years of looking for cancer signs, she started to avoid any situation where she feared she may find she had signs of cancer. Thus, she could not make her bed in the morning, or look at her used underwear for fear of finding blood spots, which to her would suggest the dreaded health problem. She even stopped looking at herself in the mirror or at her own body. She started to wear blouses and jumpers with long sleeves so that she could not see her arms, and trousers so that she could not see her legs. She stopped cleaning herself appropriately, as she feared that she would discover lumps and such like on her body. In many cases, certain numbers are avoided because the patient feels that such avoidance is needed in order to avoid some catastrophe, typically to a loved one. A fascinating illustration of this is found in the copying. A young married woman started to keep away from the number 4. Her spouse's birthday was on the 4th day of a month, and her obsessional logic dictated that if she didn't keep away from the number, she would trigger some great harm to him. She went to great lengths to achieve this. For example, she would skip the 4th page of books and publications she read, would never ever write the number 4, never eat 4 of anything, for instance, potatoes or pieces of toast, etc. Life ended up being impossible when this gradually encompassed all numbers starting or ending with 4, multiples of 4, those that were adjacent to 4, and so on, at which point she looked for some help. Disturbance. When an obsessive-compulsive patient participates in his compulsion, he needs to carry it out specifically as he feels it ought to be done. If the behavior is disrupted, then, for tons of, the compulsive routine is invalidated and needs to be restarted. For long and complicated routines, this can be exceptionally time-consuming and tiring. The events that can function as disruptors vary from sound and other external disruptions to certain classes of experiences and thoughts. The need to form a safe or appropriate thought before performing a compulsive or other act is rather common. If, as in the case defined here, the action is disturbed by an unacceptable thought, the compulsive sequence has to be repeated completely. The young man engaged in extended hand-washing routines when he felt his hands were contaminated by dirt and germs. He would normally wash them at the cooking area sink. If, at the time of this activity, he happened to see the cooking area waste bin, which he considered to be a filthy item, he felt his cleaning was ineffective, so he would restart the washing ritual. Chapter 3. More terms. There are 2 other crucial terms that are typically used to describe aspects of obsessive-compulsive disorder which need clarification. They are routine and ruminations. What is a routine? A ritual is a compulsive behavior, either obvious or psychological. It indicates that the behavior concerned has a stiff set pattern and a series of steps, with a specific beginning and end. Some examples of compulsive habits are highly ritualized. The following example shows a very fancy compulsive ritual reported by a guy in his mid-20s. This is what he had to do when brushing his teeth and washing his face each morning. Get in the bathroom with the left foot first. Close the door with the left hand, then touch door the manage with the right hand. Take the towel from the rail and keep it on the edge of the bath with the left hand, then touch it with the right hand. Take the toothbrush from the cabinet and place it on the edge of the wash basin with the left hand, then touch it with the right hand. Take toothpaste tube from cabinet with left hand, then touch it with right hand. Unscrew and remove cap with left hand, then touch it with right hand. Squeeze tube to get enough toothpaste onto brush with left hand, then touch tube with right hand. Change cap of tube with left hand, then touch it with right hand. Put television back in cabinet with left hand, then touch it with right hand. Pick up brush with left hand, then begin brushing. Teeth brushed in twos, from left to right. Top row first, bottom row next, outside first, inside next. Each set of 2 8 times, then repeat the entire process with brush in right hand, then again with left hand, followed by the same again with the right hand. Open taps with left hand, then touch them with right hand. Wash brush under hot tap, kept in left hand, then touch it with right hand. Put brush back in cabinet with left hand, then touch it with right hand. Rinse mouth, taking water with left hand, then with the right hand. Look at self in mirror first with left eye, then with the right eye. Start to wash face, using left hand to splash water on face, then right hand. Rub left side of face with left hand, followed by right side of face with left hand, then rub left side of face with right hand, followed by right side of face with right hand. Apply soap to deal with in the same sequence as above. Wash face, splashing water on face with left hand, then with the right hand. Look at self in mirror first with left eye, then with the right eye. Close taps with left hand, then touch them with right hand. Pick up towel with left hand, then touch it with right hand. Dry face with towel, left side holding towel in left hand, then right side holding towel in left hand, then left side holding towel in right hand, and then right side holding towel in right hand. Look at self in mirror, first with left eye, then with the right eye. Put that towel back on rail with left hand, then touch it with right hand. Open door with left hand, then touch manage with right hand. Leave restroom with left foot first. Most of the compulsive behavior has a ritualistic quality about it, and for this reason the term ritual is used by a lot to describe any compulsive behavior. In this book, the word ritual is used in this broad sense. Likewise, participating in compulsive behavior is in some cases referred to as ritualizing. What are ruminations? A rumination is a train of idea, ineffective and prolonged, on a specific subject or theme. Some authors and medical professionals use the term obsessional rumination to describe all obsessional thoughts, but this is misleading. An example of a rumination is as follows. A young man had complex and time-consuming ruminations on the question, is everybody essentially good? He would ruminate on this for a long period of time, discussing in his mind numerous factors to consider and arguments, and considering what superficially appeared to him to be relevant evidence. This never resulted in a solution or satisfactory conclusion. How does a rumination vary from a fascination? Unlike obsessions, ruminations don't intrude into the patient's awareness in a well-described form or with a plainly circumscribed content. Scientifically, it appears that ruminations are psychological compulsive behavior, normally preceded by a fascination. An example would be the following. The obsession, "Am I going mad?" might cause the compulsive urge to think through the subject, which in turn causes a muddled effort at thinking about it. This is the rumination. Ruminations are different from other psychological compulsions in that the latter consist of particular psychological acts, such as saying something calmly or envisioning something in a particular way. Ruminations, on the other hand, are not such well-specified events. The theme or topic of a rumination is specific, but what goes into the thinking of the topic is open-ended and variable. Many ruminations of obsessive-compulsive clients tend to concern religious, philosophical, or metaphysical subjects, such as the origins of the vast universe, life after death, the nature of morality, and so on. 2. Relationship to other disorders. We will now briefly discuss the relationship between obsessive-compulsive disorder and various other psychiatric conditions. Sadness. There is a crystal-clear relationship between obsessive-compulsive disorder and sadness. This can take some forms. Firstly, Some people develop fixations when they become depressed. In such cases, the fixations are basically secondary to the sadness and typically clear up when the desolation raises. It has been observed that amongst obsessions developing in the framework of a depressive illness, about half have a content of aggressiveness of a bloodthirsty or self-destructive nature, whereas amongst obsessive-compulsive patients, such content is found much less typically. Second of all, a lot of obsessive-compulsive patients tend to have a previous history of episodes of desolation. Finally, some of these clients be depressed subsequent to the start of their disorder and might have episodes of depression. When depressed, the signs of obsessive-compulsive disorder tend to get worse. Current research has also revealed that if the patient is extremely depressed, he may not respond well to the basic behavior treatment of the obsessive-compulsive disorder. In such cases, the desolation needs to be treated before improvement can be expected in the obsessive-compulsive signs. In view of the relationship between the two disorders, a word is needed about the functions of desolation. The major functions are seriously depressed mood, loss of interest or enjoyment in typical activities, disturbance of appetite and sleep, extreme slowing or agitation, feelings of insignificance or extreme guilt, extensive pessimism, and suicidal ideas. Morbid preoccupations. Morbid preoccupations are usually found in depressed clients and sometimes in normal people at the time of phases of low mood. There's some resemblance and overlap between obsessions and morbid preoccupations. Both include intrusive and recurring ideas. Still, preoccupations vary in considerable ways from true obsessions in that they center on sensible present problems or concerns and lack the ridiculous or repugnant quality of fixations. They are rarely withstood, and the person usually recognizes them to be logical if overemphasized. Schizophrenia. The relationship with schizophrenia is more restricted. In schizophrenia, stereotype behavior, which could look like compulsive behavior, is sometimes obvious. It is also known that in the early phases of schizophrenic health problem, fixations and compulsions periodically might appear, but these are short-term. Grievances of schizophrenic clients about thoughts that they wish they did not have can bear a shallow resemblance to obsessions, yet these are usually ideas that they believe to have been taken into their minds by external forces, human or otherwise. This feature makes these really different from obsessional thoughts, which the patient recognizes as his own. Many years ago, some writers and physicians held the view that obsessive-compulsive disorder and schizophrenia were carefully related conditions. Some even took the view that the disorder is a defense against a schizophrenic breakdown. There is no proof to support this view, and the belief in a connection with schizophrenia is rejected. The chances of an obsessive-compulsive patient becoming schizophrenic consequently are no higher than those of any other person. Though obsessive-compulsive clients in some cases do get detected or misdiagnosed as schizophrenic, that is mostly due to the superficial resemblance between fixations and delusions, intensely held personal false beliefs that schizophrenics typically hold. Normally, the two phenomena can be distinguished from one another. A schizophrenic deception is a belief intensely held by the patient, that is, he has no insight that it is false. For instance, he actually believes that the nemeses are sending out radio waves to damage him. Though an obsession is experienced as ego-dystonic, that is, not in keeping with a person's own beliefs and thoughts, and is seen as unwanted. Simply put, the obsessive-compulsive patient has insights. He knows that his obsessional belief, for example, that some disaster is about to happen to his loved one, is actually not valid. Sometimes the degree of insight fluctuates, but it isn't totally missing in these clients. Although the patient acts on the belief by performing compulsive behavior or staying away from certain things, there is the recognition, if not at the time of the behavior then a few hours later, that it is ultimately irrational. Undoubtedly, there are exceptions, but they are very little in number. In this minority of patients, the obsessional belief is held with some perseverance. In recent years, some authors have talked about such highly held beliefs in obsessive-compulsive patients and defined them as misestimated ideas. In spite of the strength of these delusion-like beliefs, a lot of these patients can eventually be encouraged to concede that they may be mistaken. Phobias. At times, obsessive-compulsive disorders are replaced with phobias, which are illogical and/or excessive fears. In view of their common functions, this is not surprising. Phobias are defined by anxiety, and most obsessive-compulsive patients experience a lot of anxiety. As noted earlier, both conditions fall within the category of anxiety conditions. In both, there is avoidance behavior. A patient with a serious phobia of spiders will stay away from going near them or to spots where he knows spiders are to be found. An obsessive-compulsive patient with an issue about dirt will avoid all places and items that he thinks consist of dirt. It's definitely the case that some obsessive-compulsive clients have some phobic characteristics, specifically those with contamination fears and associated cleaning and cleaning routines. Even so, the two disorders are different in some important ways. The ceremonial behavior of the obsessive-compulsive is absent in the phobic. Tons of the former may specify their feeling when affected by a fixation or exposed to a setting-off situation such as contact with dirt, not so much as fear but as discomfort, uneasiness, or disgust. An even more essential difference is the following. A person with a serious phobia generally can, if he effectively keeps away from the thing or situation he is afraid of, feels safe, and be unaffected by the issue in his day-to-day life. Someone with a real phobia of elevators, for instance, will avoid using elevators and will have the ability to lead a perfectly happy life as long as he's not pushed to do so. And someone with a real phobia of spiders can lead a normal life as long as he avoids encounters with spiders. On the other hand, an obsessive-compulsive patient can't get away from his problems as quickly, even if he keeps away from things that trigger his obsessions or compulsive urges. He does not feel totally free. Here is an example. Women with this disorder may absolutely stay away from knives, scissors, and other sharp items, which she fears she may use to assault people, but still regularly stress that she may commit these acts, or indeed even wonder whether she has actually attacked somebody. So, regardless of some resemblances and overlap, obsessive-compulsive disorder and phobic disorder are different from one another. Anorexia nervosa. Anorexia nervosa has been defined by some authors as a kind of obsessive-compulsive disorder. The single-minded determination to reduce weight and the incessant fixation with food, weight, and body size and shape that these clients display have been given as evidence for this. Anorexics are typically described as obsessed with thinness. However, anorexia is a different disorder, not part of an obsessive-compulsive disease, though there is some relationship between the two, and a little percentage of females with obsessive-compulsive disorder have a previous history of anorexia nervosa. Among anorexics, a large subgroup has fixations and/or compulsions, some of them rather significant. It appears that in these clients the two disorders exist side by side. Sometimes, the symptoms of the two conditions influence one another and get intertwined. That is, certain behavior presumes significance in both conditions. For instance, a teen girl had the compulsive behavior of running up and down the stairs 7 times before every meal. This had all the functions of a compulsion, but it could similarly be viewed as an anorexic behavior designed to lose weight, and it certainly had that influence. She also had the urge to leave a quantity of her food on her plate, arranged in a certain way, unconsumed. Her clarification was that she felt forced to do this. Even though she denied that it had anything to do with eating less, the behavior clearly added to preserving a lower weight. Clients with both anorexia and obsessive-compulsive problems report that their latter troubles tend to worsen when they're specifically unhappy with their weight and body size. It is also known that anorexics with obsessive-compulsive symptoms tend to show more serious anorexic disorders than the ones that do not have such symptoms. Bulimia nervosa. In bulimia nervosa, which is a version of anorexia nervosa, the patient has frequent episodes of binge eating, joined by self-induced throwing up and/or laxative abuse. The urge to take part in binge eating is described by some of these patients as having a compulsive quality, though the nature of the behavior is by no means ridiculous. As with anorexics, some bulimics also have concomitant obsessive-compulsive problems, some functions of which might become closely related to the eating disorder. For example, a girl with a history of both conditions reported that when she binged on chocolate bars, she felt obliged to eat 24 bars at a time, neither more nor fewer, and the binge needed to be continuous. If the chocolates got infected by the smell of another food, then the entire binging episode had to be rebooted. Gilles de la Tourette syndrome. This condition is identified by multiple tics, including but not limited to singing tics, which may take the form of swear words or profanities. These tics are different from true compulsions. They're purposeless and uncontrolled, unlike compulsions. Nor can they be easily delayed, reshaped, or substituted, again in contrast to compulsions. Another distinction is that the treatment techniques that succeed with obsessive-compulsive disorder are of little use with Tourette clients. It has been reported that some patients with this syndrome also have obsessive-compulsive signs, specifically the younger patients. Members of the family of Tourette's clients have also been reported in some studies to have a higher recurrence of obsessive-compulsive features than the general population. Despite of these evident associations, however, clients with obsessive-compulsive disorder seldom have the Gilles de la Tourette syndrome. Brain damage. It is understood that symptoms comparable to fixations and compulsions can result from mental retardation brought on by injury or neural disease. The patient may engage in recurring acts or reveal repetitive ideas. The appearance of obsessive-compulsive type symptoms in certain organic conditions, for instance encephalitis lethargica, has been recognized for tons of decades. These symptoms are normally accompanied by other signs of mental retardation, such as deficits in memory and learning capability. Farther, the repeated acts and ideas of these clients are different from fixations and compulsions in that they lack intellectual content and intentionality and have a mechanical or primitive quality. Studies brought to examine neurological and neuropsychological functions of obsessive-compulsive patients have not produced consistent or specific results. It's safe to say that there is no evidence of any brain damage in the huge bulk of obsessive-compulsive patients. Chapter 4. An Obsessive Personality. Different views have been uttered on the relationship between obsessive-compulsive disorder and obsessional personality, also called compulsive personality and anancastic character. By obsessional character, we mean a group of enduring qualities in a person, which includes orderliness, meticulousness, parsimony, obstinacy, neatness, and perfectionism. According to some writers, obsessive-compulsive disorder is only an exaggerated stage or variation of an obsessional character. This is inaccurate. Obsessional characteristics are acceptable to the person, hardly ever cause distress, are hardly ever accompanied by a sense of compulsion, and similarly seldom provoke resistance. Maybe even more importantly, these personality traits show much greater stability than obsessive-compulsive disorder. An associated view is that the premorbid personality, that is, the personality before the onset of the disorder of obsessive-compulsive clients, is of the obsessional type. Though neither of these views is verified by acceptable evidence. It is actually true that a percentage of obsessive-compulsive clients do have an obsessional type personality, but a lot more with really different character features also develop the disorder. On the other hand, a very big majority of individuals with obsessional personalities never ever develop obsessive-compulsive disorder. If we were to search for any single character type that's connected with the disorder, It is maybe best described as mindful and introverted, rather than obsessional. Even this needs to be viewed as only a very general observation, for there are many exceptions. Compulsive personality disorder. Individuals with obsessional personality functions to a degree that seriously influence their life and functioning are sometimes scientifically referred to as experiencing a compulsive personality disorder, also called obsessional personality disorder or obsessive compulsive personality disorder. In these patients, the main features are long-standing personality types like excessive rigidity and perfectionism, excessive preoccupation with specifics, indecisiveness, and so on, and not episodes of disease. Those functions are well established by early the adult years. Moreover, these people tend to show a lack of or limited capability to reveal warm and tender feelings. They do not necessarily have or develop true fixations and compulsions. In clinical practice, such clients are experienced only seldom, and when they do come for help, it is normally due to a depressive or other illness. It has been observed that this disorder is more common in males than in females. Obsessive-compulsive patients. There are several typical forms of obsessive-compulsive disorder. Most clients have more than one problem, but normally there are one or two that are primary at a given time. At the time of coming for help, tons of also show general anxiety, low mood, disappointment, and considerable general distress. Chapter 5. The main types. A hassle-free classification regarding scientific discussion is given right below. 1. Those with washing or cleaning compulsions as the significant issue. 2. Those with checking compulsions as the significant issue. 3. Those with other obvious compulsions as the major issue. 4. The ones with obsessions unaccompanied by overt compulsive behavior. 5. The ones with primary obsessional slowness. Washers or cleaners. This is the commonest clinical presentation. Normally, the patient has obsessions about contamination by dirt or germs, or contamination from something more particular like urine, deals with seminal fluid, animal fur, asbestos, and so on, and associated cleaning and cleaning up rituals. There is also avoidance in an attempt to avoid contact with dirt or other sources of contamination or pollution. The washing and cleaning up can be severely extreme. In many cases, this includes washing a person's turn over 100 times a day, using bottles of cleaning agent, using hundreds of toilet papers, bathing or bathing for several hours, cleaning and wiping tabletops, chairs, and floors for much of the day, and so forth. The reasons given for the washing or cleaning are varied. Typically, it is for the purpose of getting rid of dirt or bacteria. That is connected in some to ensuring that a pretty serious health problem, such as cancer, is not contracted. In many cases, the cleaning is focused on safeguarding others from the spread of bacteria. A few say that they need to take part in the washing and cleaning ritual just to avoid the great anxiety, even panic, that would take place if it wasn't promptly done. The avoidance can be extensive. The patient may not touch items that others have touched, such as doorknobs and public telephones. He might avoid using public toilets and avoid sitting on chairs which others have rested on. Or, if he did, would first cover it with a towel or cloth or sit on the edge. In severe cases, the whole world other than a little area in somebody's home is kept away from. One woman was so concerned about dirt and bacteria that she felt free only in her bedroom and the restroom, which she did not allow anybody else to enter. When she headed out, she wore a very large coat and gloves, which she instantly cleaned upon returning. Another patient felt some safety only when being in her unique chair in the house. She disinfected her chair daily. There is a surplus of women over males among those whose primary issue is washing or cleaning. The following is a case illustration. A girl had obsessions about dirt and related compulsions. Her main concern was about excrement, both human and animal. She would wash thoroughly after returning from a walk, even if she did not actually see, let alone step on, dirt. That was because she felt that pet dog dirt is spread out all over the roads and pavements by rain and wind. She would leave her shoes out at the door and change into a different set before entering the home. She totally kept away from public toilets. As the issue worsened, she began to stay away from going everywhere near manholes, as they showed the presence of sewage systems with human excreta beneath. She would keep away from parts of roads in her area where she knew there were manholes. By the time she came for help, she had practically completely stopped going out, had left her job as a result, and had begun to spend much of her time in bed. She had also begun to demand that her parents, with whom she lived, stop going out, as they would bring dirt into the home when they returned, and to insist that they left their shoes outside and cleaned their hands and feet when they returned from a trip. Here is another example. A married woman in her mid-30s developed a severe and prevalent fear of contracting cancer through contact with anyone or with things that had come close to a person with the illness. She recognized that her fear was clinically groundless, but despite this, her fear was intense. In order to lower the chances of contracting cancer, she spent hours each day cleaning and decontaminating herself and her clothes. She didn't feel safe going out, and so didn't leave her home other than for the most urgent of reasons. She felt more secure in one room of the house, and on one chair in particular. Her hands were red, inflamed, and abraded, due to the excessive washing. The hands of a lot of compulsive hand washers show clear signs of extreme cleaning. The repeated cleaning tends to dry the natural oils of the skin, and frequently causes marked dryness, especially in the parts between the fingers. Fear of dirt and bacteria. Patient's account. The following is a female patient's own account of her washing and cleaning compulsions. She was in her 50s and resided on her own in a house. I can't touch anything that I think is filthy. It is mainly the toilet, but then when you come out of the toilet, you bring the dirt and bacteria out into other parts of the home. I always wash my hands lots of times before I leave the toilet. I keep my shoes and slippers outside the door of the toilet so I can enter them as I come out. No, I would never use a public toilet. Never. I almost passed away when once a boy who came in to repair something used my toilet. He just came out and went on touching things and perambulating the place as if everything was fine. I could not tell him to stop, but it was so horrible. I cleaned and cleaned all over the home after he left. I used disinfectant on the things he touched, even the important things he went near. I do not like people entering into my home, not even good friends anymore. My bedroom I somehow keep clean. Every other part of the home is really unclean, however much I clean up. The towels I have in the toilet I clean independently, never with my other things. When I feel I'm dirty, I clean and wash, with a ton of soap, and with Dettol and whatnot. The entire flat gives off disinfectant. I feel fine for a while when I have cleaned, but when I go to the toilet again, even to pick up something or to open the window, it starts all over again. I don't think I can enable myself to be touched by anybody. I keep my gloves on when I am in shops or on the bus. All the outfits I wear for outside, I never ever bring into the bedroom without first cleaning them. If the bedroom also got dirty, then I would be finished. Where could I go? That is the only clean place which I have. The Bacterium War of Howard Hughes. It is well known that the late American millionaire Howard Hughes had serious contamination fixations and related routines and avoidance behavior, particularly in the years 2015 of his life. Among other things, he had complicated rituals for dealing with objects. Here is an example. Before handing a spoon to Hughes, his attendants were required to wrap its handle in tissue paper and seal it with cellophane tape. A second piece of tissue was then covered over the first protecting wrapping. On getting the spoon, Hughes would use it with the deal still covered. He had even more detailed guidelines on a lot of other things, all associated with his great fear of germs and contamination. and his staff needed to follow these instructions really strictly. Normal of these were his directions on how to eliminate his listening device's cable from the bathroom cabinet. First and foremost, 6 to 8 Kleenex tissues needed to be used for touching the doorknob to open the bathroom door. Then the taps were to be opened, using the exact same tissues to get warm water. After that, 6 to 8 new Kleenex tissues were to be used to open the cabinet which contained the soap, and an unused bar of soap taken. The hands were then to be washed extremely completely, making certain that they didn't touch the taps or the sides of the bowl. After this, 15 to 20 new Kleenex tissues had to be used to turn off the taps. Now the door of the cabinet which contained the listening device's cable was to be opened using at least 15 Kleenexes. Absolutely nothing inside the cabinet was to be touched in any way, other than the sealed envelope which included the cord. This was to be eliminated with both hands using at least 15 Kleenexes for each hand. Only the centers of the tissues were to be allowed to come into contact with the envelope. On those occasions when his staff needed to touch him to wake him up, Hughes's directions were that the chosen person must pinch his toes with 8 densities of Kleenex tissues, applying progressively greater pressure till he got up. Checkers. Those with checking compulsions form the next biggest medical group of obsessive compulsives. Males and women are found in roughly equal numbers in this group. Those clients take part in extreme checking routines. A common checker will consistently check things like gas taps, ovens, electrical devices and switches, door locks, windows, cupboards, drawers, cabinets, or files. Many checkers have numerous of these as their checking things. The monitoring is connected with fixations which take the form of doubting, such as, "Did I turn off the gas? I could have left the oven on. The door must have been left opened," etc. Checkers worry a great deal with these doubts till they check and reconsider. Checking once is insufficient. Usually it is a lot of times, not rarely a fixed number of times, and even then, some clients could feel vaguely dissatisfied. The checking requires time. It can be very humiliating if others see it, and it can be disabling. One girl was not able to park her car and leave it till she had checked all the switches, radio, aerial, and all windows and doors sometimes. She would walk round the automobile looking and checking before leaving it. Some patients drive back home from halfway to work to check their gas taps, light switches, and door locks. Most checkers aim to make sure that they have not left any chance of harm coming to themselves or others. Their fear is that there will be disasters if they don't guarantee that whatever they are worried about is appropriately checked. A middle-aged plumbing professional had to check and reconsider every pipes job he had done, however small. If he did refrain from doing this, he felt that the pipelines would rupture and the building would be flooded. He, in some cases, developed excuses to return to houses where he had worked to do his monitoring. In some cases, the disasters feared are remote and not in any way linked to the behavior, such as air crashes including loved ones and even earthquakes. While many checkers are worried about things like doors and gas taps, which many people will check, though not exceedingly, some checkers have less quickly understood concerns. A patient could check every chair for pins or sharp items or for pieces of glass. An example would be the following. A young man compulsively checked every garbage bag that he walked past to make sure that it consisted of just rubbish and not a corpse. Another man repeatedly drove back along the way he had just gone to check if he had torn down a pedestrian or an animal. The following is a case example of a checker. A man in his late 20s was referred with extensive checking behavior. He felt compelled to check that everything was right, so he would return over almost everything he did. The most serious doubts he had to do with doors, windows, and gas taps, which he checked sometimes before leaving the home in the early morning and before retiring to bed during the night. He also checked anything that he wrote several times, which delayed his work substantially. He could not put anything in an envelope or a file, drawer, or cabinet without consistently checking that he had written precisely the right thing. He usually tore open sealed envelopes to reread what he had written. He also checked the dates of newspapers. While reading a newspaper, he would check repeatedly that it was that day's, even if it had just been provided to him. Some of his checking, he felt, was necessary to stay away from fires, the house being burgled, the bathroom getting flooded, and so forth. For the rest, he had only a vague notion that it was necessary to stay away from some unspecified disaster. At the time that he came for help, he was severely impacted by the issue. Absolutely nothing could be left unattended, and his work was becoming unrealistic. The patients in these examples had an exaggerated sense of responsibility. They felt that it was incumbent on them to prevent mistakes or disasters from occurring, and to this end felt obliged to perform their checking routines. When the gut feeling of responsibility of such clients is moved or suspended, the compulsive monitoring tends to decrease and even stop completely. So, for instance, a woman who carries out repeated checks of the light switches, gas taps, and so on in her own home is free of these compulsions when going to the houses of others. If these people are admitted to health center for inpatient treatment, they generally show little or no monitoring behavior in the first few days. As they settle in, however, they start to feel responsible for the security of the ward, and after that their monitoring reemerges. Those with other obvious compulsions. There are some whose main issue includes compulsions which don't fall into the above classifications. There is no preponderance of either males or females in this heterogeneous group. Some repeat certain behavior, like getting dressed or undressed several times. Some have to do things in a specific way. For instance, a strict sequence needs to be followed in preparing a meal or setting the table. Each step is strictly predetermined regarding its place in the sequence of behavior. Some have touching compulsions, touching corners of a room, touching with one hand what has been touched with the other, and guaranteeing equal contact time for each hand are examples. Some of the behavior appears bizarre to others, and clients could try to hide the compulsive behavior. The reason that many of these patients give for doing these things is generally the same as that given by checkers. If they did refrain from doing it, some risk or damage would happen, normally to a loved one. In some it is really particular, while in others it can be an unclear feeling of damage or danger. For several patients, the compulsion is not a way of fending off any harm. They say they just have to do it, since if they did not, the feeling of pain or anxiety would be too great to bear. Another compulsion is hoarding. The patient feels compelled to hoard or gather large numbers of generally insignificant things, and discarding things is really challenging. Old newspapers and files aren't discarded for fear that there might be something essential in them. Some clients go to great lengths to retain their extravagant collections, typically filling lots of boxes and even dedicating entire spaces for this purpose. Any recommendation that these needs to be dealt with meets with stiff resistance. One middle-aged man who resided on his own had his whole corridor blocked with old papers, marketers' notices, free news sheets, etc. His clarification was that he could not throw them away without first monitoring each product to make sure that he didn't miss out on anything essential. Naturally, he could never ever do this monitoring satisfactorily. Each time he checked a newspaper, he was convinced he had not done it properly, so nothing was dealt with. There are others who hoard cans of food, old clothes, and various useless items rather unrelated to checking. Another fascinating compulsion is list-making. The patient makes lists of things to do, things to purchase, people to telephone, and so on, well past the bounds of reason. One girl had to make a detailed list each morning of each single thing that she had to do throughout the day, including such basic routine things as having breakfast, going to the toilet, putting on shoes, and so on. When each behavior was completed, it was crossed off the list. Items not on the list could not be performed. This behavior was so lengthy that she was late for every little thing. When her mom once took away her notebook, she began to write on the palms of her hands. This has been OCD, Obsessive Personalities and Disorders Explained. Written by Sid Van Roy. Narrated by Doug Green. OCD, Questions and Answers About Common Symptoms and Treatments. Written by Sid Van Roy. Narrated by Doug Green. Chapter 1. Looking for Help. Once it is recognized that there is an issue, the best strategy is to look for expert guidance. In some cases, it could be possible to deal with the troubles without option to such help, but most of the times, seeking expert guidance is the best action. Looking for a therapist. The initial step is to go to your own medical professional and explain the issue. There is no need to fear that he will think you are strange or crazy. He will recognize that this is an issue needing help and refer you to an expert who is experienced in handling it. That will generally be a medical psychologist or a psychiatrist or, where readily available, a nurse therapist with unique training in dealing with problems of this kind. Extremely. Your medical professional might himself give you advice and treatment if he has a specific interest and experience in this area. The psychologist or psychiatrist to whom you are referred is likely to be somebody with a behavioral technique in view of the success of this method in dealing with these issues. If the doctor is uninformed of an appropriate therapist in your area, you or your medical professional could contact the British Association for Behavioral Psychiatric Therapy, BABP, who will advise on therapists in the area. This will, however, be unnecessary in many cases, because the regional psychiatric health center will normally be able to carry you to an ideal professional. Lots of these therapists are in the National Health Service in Britain, but if, for some reason, you would prefer to see someone privately, the BABP will have the ability to advise. General advice on the services of scientific psychologists and psychiatrists could be obtained from their respective professional companies, the British Psychological Society and the Royal College of Psychiatrists. Guidance is also obtainable from MIND, which is the National Association for Mental Health, and the organization called Phobic Action. In the United States, the OCD structure, set up several years ago, provides information and guidance for victims of obsessive compulsive disorder and their families and friends. Many have found contact with the structure, which is a voluntary and non-profit-making organization, to be incredibly beneficial. Another company that provides beneficial info and advice on this disorder is the Anxiety Disorders Association of America. The Therapist's Evaluation. When you go for your preliminary assessment, the therapist will try to gather as much relevant information as possible. It may well take more than one interview for him to finish the assessment. Your therapist could also give you some questionnaires, checklists, or stocks to complete. He could ask you to carry out short tests. Here is an example. If your issues include a fear of contamination or dirt, he could ask you to touch with an open palm of your hand table surface areas, tops of cupboards, and so forth. Or, if you have horrific ideas and impulses that you may stab a person, the therapist may ask you to hold a knife or set of scissors in your hands and to specify to him what ideas, images, and impulses come to your mind at the time. He may also give you some homework in the form of keeping a journal or record of your issues as they happen in the next week or two. Cooperate with this even if you think it is a task. The therapist is also likely to want to interview a family member or good friend, and you may be asked to organize this. He might also want to see you in the home to see for himself what your problems are and how you cope. Naturally, this will depend on the nature of the problem and on how much time the therapist has at his disposal. Many therapists nowadays, if they can find the time, are very likely to include a home visit as part of the assessment, specifically when you have routines which you perform in the home or home-related avoidance behavior. Planning and execution of therapy. In planning the treatment program, your therapist will go over with you what parts to focus on, what targets to be aimed for, and how to approach achieving these targets. The involvement of a member of the family as a co-therapist is very likely to be talked about, and she or he will be included in the conversation of homework arrangements and related matters. If the problem is hard to manage on an outpatient basis, hospitalization for a limited period will be considered. Healthcare facility treatment will include not only your therapist but nurses and other specialists as well. A family member could also be invited to take part in some health center sessions, who can then assist with the next stage of therapy from healthcare facility. If your treatment is totally on an outpatient basis, as is rather possible, the therapist could perform or schedule some added sessions in your home. These household sessions can be incredibly valuable, and many therapists consider them to be vital. Irrespective of this, you are going to be given a lot of guidance and guidelines about what you should and should refrain from doing at home. An example would be the following. You could be told that you should not clean at all except for an everyday 5-minute shower, or that you should disarrange your desk and wardrobe and leave them like that. The implementation of such directions will be left to you and or the family member serving as co-therapist. Do not be amazed if the therapist asks you to continue to keep routine records of what happens in the house, as this information is valuable in monitoring your development. He might wish to go over your home records and discuss them in detail at the start of each session. If a direct exposure and reaction prevention program is carried out in an outpatient clinic, at least some of your sessions with the therapist are likely to be rather long. That is because the therapist will want to guarantee a significantly long response prevention period to allow your pain to dissipate. Additionally, part of each session is likely to be dedicated to conversations between you and the therapist. He could wish to explore your fears of disaster, your difficulties in homework, what you truly think will happen if you don't ritualize, etc. There may also be imaginal exposure. An example would be the following. If your fears include a worry that if you don't check the gas taps 3 times, the entire home will burn down, your therapist could ask you to close your eyes and very vividly imagine such a scene. Such imaginal exposure could be performed in some sessions. Sometimes, real-life exposure to a specific circumstance could be preceded by you being asked to go through the experience in your imagination. In some, your sessions are very likely to be lengthy, specifically at the start, and also to include different activities. The primary ingredient, though, will be exposure and response avoidance if your primary issues are correctable in this way, along with detailed homework instructions. If your primary problems are of a much different kind, such as repetitive unwanted ideas without any associated overt rituals, then your treatment sessions will take a completely different form. Even then, homework is most likely to be part of the program. If your main problem is slowness, then much of the therapy might well be home-based. An additional word is needed about the participation of family members. The role that a co-therapist plays will be plainly described and detailed, and particular guidelines given. That is in order to keep away from any uncertainty causing conflict. The family will also receive guidelines about not complying with your demands, or ask for reassurance. All of these will have been discussed fully and freely with your active participation. Any doubts or queries you could have, you should discuss fully with a therapist. The need for cooperation. It is necessary that you cooperate completely with the therapist, your co-therapist, and any others included. Carrying out some of the guidelines could be extremely tough for you. For example, the task of rubbing your hands on the kitchen floor and after that not washing your hands. But it is very important that you do your best to comply. The trouble will typically get progressively less with a lot more sessions. If you find that you're in some cases lured not to comply totally, for example, you might just feel like washing your hands secretly, or touching the floor only really gently with the ideas of your fingers, it is important that you discuss it with the therapist. Remember that treatment for these issues is essentially a joint endeavor. Your therapist has no magic remedy, and without your cooperation can achieve nothing. Half-hearted cooperation will only lose your time as well as your therapist's. So talk about any issues with him. He will really appreciate your troubles and discuss them with you. If for some reason you clean when you are not supposed to, you can remedy this to some degree by instantly recontaminate yourself by touching the infecting object. It can, in essence, be tough work. However, if you're motivated to get over your problems, you're going to find that with the help of your therapist you can keep it up. Periodic lapses should not be viewed as failure. Do not let them discourage you. When you start to see the results of your efforts, you are going to be extremely glad that you underwent the treatment. It will make a big difference. Modification issues. When you slowly enhance with treatment, you could well find that you need to adapt to a new lifestyle, specifically if your problems have been long-standing. You'll find a ton of leisure time and probably few activities to fill that time with. You will really need to develop new ways of filling your time and maybe new activities. You might need to reestablish old contacts and relationships. Your therapist will generally talk about these matters with you and also give advice and counseling on how to make these modifications. It is possible that your family members will also have similar issues if their lives had been molded around your issues. After therapy. When you have achieved improvement, do not expect to be completely without signs. What normally happens, in cases where the issue includes interrelated obsessions and compulsions, is that the compulsive conduct is brought under control with the exposure and reaction avoidance treatment fairly rapidly, but the obsessional ideas might not disappear at the same time. They may linger on, but without exciting much pain or leading to a strong compulsive desire. After a time, you're going to notice them less and less, and they may well vanish completely. You might still have small residual issues, and perhaps continue to be a more restless person than lots of others. Do not be too disappointed at this. You can learn how to handle these. With the significant disabling problems largely out of the way, such coping will be much easier. Once effectively treated, the chances of a major regression aren't really high, yet there could be small lapses. Sometimes of stress, for example with problems at work and so on, the chances of symptoms coming back could be rather increased. You can reduce the impacts of tension if you use techniques to manage situations. Relaxation practice is one such method. If symptoms of the disorder do come back, you'll see these signs early on and give yourself a few booster sessions using the concepts of treatment you are now familiar with. It's also not uncommon for a therapist to have set up boosters at different time periods. He will, in any case, have scheduled follow-up consultations for you in order to determine how well you are doing and to give you help and support as needed. If you feel that you're losing control again, contact your therapist, even if there is no follow-up arrangement. It must be restated, however, that after a carefully planned conduct treatment program has been successfully performed, the chances of the issues reemerging in full-blown form are limited. The application of drugs. It is possible that your therapist will consider drugs as part of the treatment, as only a physician can recommend drugs. If your therapist is not a health professional, he will ask your own medical professional or a psychiatrist he deals with to consider this. The most likely situations for this would be if your state of mind is depressed, and this has either stalled your progress or is making it challenging for you even to engage in the treatment. In such cases, antidepressant medication may be prescribed, or your doctor may want to start the treatment of your obsessions and compulsions with a drug. Whatever drug is recommended, it is really essential that you tell the physician what other medications you are taking, any allergies that you have, whether you are pregnant, and so forth. Make certain you get really clear instructions about the dosage and what foods and beverages, if any, to keep away from, and discuss possible adverse effects. Typically, prescribed antidepressant drugs, including clomipramine, have some popular side effects. Those are, though, reversible. When the drug is stopped, they will clear up. Two other points are definitely worth remembering with regard to medication. The first is that antidepressant drugs don't produce results instantly. It may be weeks before any enhancement is seen. Second, if you're treated with an antidepressant drug and no behavioral treatment, enhancements in your obsessive-compulsive symptoms might decrease or disappear when you come off the drug. If you are on anxiety-reducing drugs at the time of looking for help from a behavior therapist, he may suggest that you discuss with the prescriber whether the drugs should be withdrawn or at least decreased before therapy starts. The recommending doctor will be fully involved in these conversations and decisions. If you are in the routine of drinking high amounts of alcohol, you'll be asked to decrease this. Brain surgical treatment. It is incredibly not likely that your therapist will recommend brain surgical treatment unless your issues are really persistent, absolutely resistant to other forms of therapy, and you are paralyzed by them. This will not even be considered. If psychosurgery is proposed, you don't need to agree to accept this procedure, and you would be well advised to seek a second and even a third viewpoint if you wish to consider it. Even then, the final decision will be yours alone. Generally, this form of treatment is best stayed away from. When it is suggested, the really fullest assessment and conversation are needed. Chapter 2. Treating Yourself. Is it possible for someone with obsessive compulsive disorder to treat himself? Current research done in a major London medical facility has revealed that some patients treating themselves do practically, and those treated by therapists. But in this case, the assessment and preliminary guidance originated from certified and experienced therapists. Can you do the whole thing yourself from start to end up? If the problem isn't really extreme, and if there are no other issues, this is not impossible. You really need a commitment to the scheduled treatment and an organized method. If you are seriously depressed, though, then you should not attempt this. Apart from this, if you habitually take a ton of alcohol or drugs like benzodiazepines, self-help ought to not be attempted without first consulting your physician. The nature of the problem is also essential. Clear, overt routines and clear avoidance conduct which is well specified, are likely to be more amenable to self-treatment than incessant ruminations or complicated mental routines. You really need to decide whether yours is the right kind of issue to treat yourself. Choosing targets. The first requirement is to pick and specify a small number of targets associated with your issue. Consider what elements of the problem you really need to enhance in most. Then formulate the target very specifically. An example would be the following. You might decide that one of your targets will be to be able to empty the kitchen waste bin into the main dustbin each night, or to be able to leave home every early morning without checking the gas and electrical power more than once. Those are good practical targets. More global targets like to get rid of my fear of contamination or to be devoid of repeated monitoring and doubting are less helpful and tough to make use of in treatment programs. So, be specific in setting targets for yourself. Do not attempt to deal with too many targets simultaneously. It is recommended to begin with just one or two at the most. As therapy advances, you can add on new targets to your program as you master the original targets. Getting the help of others. If at all possible, enlist the help of a co-therapist to whom you are going to explain your problems and the therapy plan totally. The co-therapist could be your wife or husband, a relative living in the house or close by, or a friend or a trusted co-worker for certain types of targets. It is a really good idea to document with your co-therapist precisely what his role will be and your commitments to him. For instance, not to argue when he reminds you to do something. Clearly, if your problems include others being asked to comply with your needs, or to offer you with reassurance and so on, then they really need to be told not to comply anymore, in relation to the targets you are working on. Chapter 3. Q&A about kids. What is the cause of OCD? There are probably several reasons for OCD. No specific causes have yet been determined, and OCD may actually be the single way the brain responds to multiple issues. That reaction resembles the minimal way the intestinal tracts might produce diarrhea as a reaction to a range of issues like bacterial infections, viruses, parasites, food poisoning, anxiety, and malabsorption. Just one thing is clear, nevertheless. OCD is a biological disease of the brain. Adding to this natural aspect are different environmental elements that also play a role. So, although the specific causes of OCD aren't fully comprehended, a mix of natural and environmental elements seem to produce it. Some of the recognized causes are noted here. The cause that appears to be best comprehended connects to biochemical factors. Anatomic elements. Injuries to certain regions of the brain can produce OCD signs. Conversely, in extreme OCD that's unresponsive to regular drugs or other treatments, surgical treatment on a certain part of the brain has produced symptomatic improvement in some of these formerly non-responsive clients. There are lots of clues seen in studies using computed tomography, CT scans, positron emission tomography, animal scans, and magnetic resonance imaging, MRI, demonstrating numerous irregularities in the frontal cortex and other areas in the brain. Some studies have revealed increased or reduced metabolic activity in various parts of the brain. Other research studies have shown problems in one of the electrical circuits that sends nerve impulses to numerous other parts of the brain, in particular the corticostriato-thalamocortical circuit. Irregularities have been found in the prefrontal cortex, which is the decision-making part of the brain, and in parts of the motor and sensory relay stations in the thalamus. Biochemical elements. The brain is certainly a really intricate structure. It contains billions of nerve cells, neurons, that must communicate and function well together. They communicate through electrical signals from one nerve cell to the next. Some brain chemicals, called neurotransmitters, move the electrical messages from one nerve cell to another. Neurotransmitters travel from the end of one nerve cell, the sending or sending cell, to the start of another cell, the receiving cell, right across fluid-filled tiny spaces between the cells known as synapses. To send messages between the cells, neurotransmitters should leave the sending cell, cross the synapse, and bind or attach to a receptor site situated on the getting afferent neuron. There are many substances in the brain that serve this function in the numerous parts of the brain. In OCD, there are a lot of neurotransmitters that appear to contribute: serotonin, dopamine, glutamate, and possibly others. Serotonin, also called 5-hydroxytryptamine or 5-HT. Proof suggests that serotonin is a crucial element in OCD. Drugs that impact the serotonin system produce improvements in OCD symptoms. In children receiving drugs that increased serotonin levels in the brain, certain parts of the brain, that is, the caudate nucleus, that were abnormally big right before treatment, decreased in size, and the OCD signs improved. In OCD, there seems to be an issue either with serotonin levels or with damage at the receptor site in the receiving cells obstructing or preventing the serotonin from sending the electrical messages. Supporting this idea is the discovery that many OCD clients gain from the application of a class of medications known to enable more serotonin to reach the receiving nerve cells. These drugs are called selective serotonin reuptake inhibitors, SSRIs, and are also effective for the treatment of desolation. Dopamine. Similarly, proof suggests that dopamine, another neurotransmitter, contributes in OCD. On brain scans of clients with OCD, there is increased activity in one of the dopamine areas of the brain called the basal ganglia. In clients with recognized diseases of the basal ganglia, OCD signs are frequently present. An example would be the following. In clients with pseudonym chorea, brain imaging and spinal fluid research studies have shown differences in the neurotransmitter systems between clients with OCD and clients without any OCD. Medicines that block dopamine have been used with some success to enhance treatment in patients who don't respond well to serotonin drugs only. Hence, dopamine, too, seems to play a role in OCD, and this has led to the application of drugs that work on both dopamine and serotonin neurotransmitters. Glutamate. Brain imaging and back fluid studies have revealed distinctions in the glutamate system between OCD patients and healthy volunteers. Dysfunction of glutamate neurotransmission has been linked in the causes of OCD, and recent medical reports suggest that some drugs that work on glutamate are effective in the treatment of this disorder. Oxytocin. Oxytocin is a hormone that assists in giving birth by increasing throughout labor and in subsequent breastfeeding. Somewhat surprisingly, it also works in the brain as a neurotransmitter, having nothing to do with female reproduction. There is some evidence that oxytocin contributes in OCD, though how and when are not clear. Some grown-ups with OCD have been found to have elevated cerebrospinal fluid levels of oxytocin. Some clients with Tourette syndrome who also had OCD had low levels of cerebrospinal fluid oxytocin. Does my daughter understand that this isn't normal? Most kids with OCD recognize that their fixations are originating from their own minds and are not reasonable. They see that the compulsions they perform are extreme and unreasonable. Their insight is good in these cases. However, some kids do not have good insight and don't realize that their beliefs and actions are unreasonable. Young children in general have poor insight about these problems and might not even have the ability to specify their symptoms well. They might not have the cognitive capability to comprehend the nature of the fixations and compulsions, which could delay the diagnosis. Another concern is oppositional kids or older adolescents who could not want to admit there's something wrong with their behaviors. They might try to hide their actions and concerns, which can make analysis quite tough. My young daughter is always stressed over numbers. Is this uncommon in OCD? And what other types of obsessions may she have in the future? So many types of obsessions have been described. Common ones include contamination fears of bacteria, dirt, or ecological toxic substances, disgust with bodily wastes or secretions, fears that they're polluted or that they may contaminate others, the worries of having unintentionally harmed someone else, the worry that something horrible may happen, or fire, death, health problem of a loved one, harm to self or others, the worry of losing control of aggressive urges, intrusive sexual ideas, urges, or images, excessive spiritual or moral doubt, forbidden ideas, an important need to have things so, a need to admit, to tell, or to ask something, a need for balance, order, or exactness, issues about fortunate or unfortunate numbers, fixation with sounds, words, or music, preoccupation with home items, for example, toys, knives. These are just some common examples. There are many others defined by clients, and some could be affected by the society or environment of the kid, that is, cartoon characters, movies, stars. Is it possible that my child can be physically ill because of so much stressing? Children with OCD often do not feel well and are susceptible to stress-related ailments like headaches or indigestions or irritable bowel syndrome. They are usually worn out as a result of a lack of sleep, as they're not able to go to sleep as a result of their worries, or due to going to bed late after performing their rituals. These kids are typically described at a mental health center by a pediatrician who recognizes the OCD symptoms, by a dermatologist who was sought advice from for irritated skin because of prolonged showers or regular hand washing, or by a dental practitioner sought advice from for weapon issues related to the child's extreme brushing. Are there brain or neurological illnesses that produce OCD symptoms? Could my child have a brain tumor or cancer? There are some neurological illnesses that could produce symptoms comparable to OCD. Those illnesses include Tourette syndrome. This syndrome is characterized by multiple tics, uncontrolled quick movements or vocalizations. Individuals with Tourette syndrome could also have OCD and/or attention deficit hyperactivity disorder, ADHD. Up to 50% of people with Tourette syndrome also have OCD. but only a little percentage of kids with OCD have Tourette syndrome. This disorder is usually inherited. Relatives of individuals with Tourette syndrome may have OCD without tics. Encephalitis. Encephalitis is a swelling or infection of the brain, normally as a result of germs or infections. Encephalitis can present with OCD signs. Sydenham chorea. This disease is characterized by rapid, uncoordinated, involuntary, non-repetitive jerking movements impacting mostly the face, feet, and hands. It arises from childhood infection with group A beta hemolytic streptococci. Epilepsy and seizure disorders. Epilepsy is a recurring seizure disorder brought on by unusual electrical discharges in the brain. It makes up a group of disorders for which persistent seizures are the primary sign. The different forms of epilepsy are either secondary to a certain brain abnormality or neural disorder, or are said to be idiopathic, without any clear cause. Epilepsy can present with OCD symptoms. ADHD. This disorder might also be due to neural issues in addition to being considered a psychiatric issue. OCD is really believed to share a genetic element with ADHD. Brain injuries. Beginning of obsessions and compulsions following a brain injury has been defined in children. Temporal lobe pathology. OCD symptoms have been seen in combination with temporal lobe epilepsy. Basal ganglia conditions. The basal ganglia in the brain represents a processing area for information. It also manages voluntary movement, balance, and reflexes. OCD signs have developed in older patients who had an infarction in their basal ganglia. A case was defined of enlargement of the basal ganglia in a teen who had pandas and developed OCD signs. These medical diagnoses are also complex and require the help of a neurologist and other health tests, for example, electroencephalograms, scans. Brain tumors or cancers that present or start with OCD-like symptoms are rather uncommon, and there are only a few reports of such cases in the medical literature. The likelihood of a growth or cancer that presents with OCD symptoms is extremely low. Do children with OCD experience delusions? And what is the difference between a delusion and a fixation? What is the difference between a deception and a miscalculated idea? Deceptions are uncommon in kids, so they are generally not seen in kids with OCD. A misconception is an unshakable belief in something incorrect. The belief isn't one normally accepted by other members of the person's culture or subculture, that is, it isn't a post of spiritual faith. These unreasonable beliefs defy normal thinking and stay firm even when overwhelming evidence is shown to challenge the patient. Misconceptions are exceptionally fixed and impossible to change. Overvalued ideas are short-term strong beliefs representing a false or exaggerated belief sustained past reason or logic, but with less rigidity than a delusion. They are less amazing, and the patient could modify his or her idea rather with treatment. An obsessive thought is a recurrent and consistent thought that is experienced as intrusive and inappropriate, and that cause marked anxiety or distress. What is routine play, and is it always unusual? What is the distinction between a typical kid's ritual and that of a kid with OCD? Ritualistic play, superstitions, repeated behaviors, and games are seen in all kids sometimes during their development. There is actually a broad spectrum of ceremonial habits and actions, and it is only when fixations and compulsions transfer to the extreme that they're considered to be signs of OCD. Rituals are used by children to master typical developmental stress and anxieties and to aid with socializing. At about 2 years of age, it is quite common to see numerous bedtime routines and the demand that things be so. The usual and familiar way is chosen at mealtimes, bathing, and bedtimes. Shifts are tough, and there's often some anxiety about separation. By 3 or 4 years of age, kids be less stiff about their rituals and are more comfortable in handling change. For example, they could still be scared of the dark and want the parents to stick with them longer by involving them in some sort of ritual before bed, like story reading or tucking in. Regular contamination fears are seen at 6 to 11 years of age. For example, boys say that girls have cooties and they try to keep away from touching them. By age 7, many kids gather objects as a pastime. This gathering is not the same as hoarding, saving useless things. As a hobby, kids gather things significant to them and their peers. By age 8 or 9, kids don't really need the old routines, and only periodic peace of mind is needed. Ritualized play changes from being a singular game to group have fun with rules in the games that need to be followed in a particular way by all of the children. Throughout teenage years, it is rather common to see kids becoming obsessed with a motion picture star, gathering the person's photos, or spending days playing a favorite game related to this person. It is just a concentrated interest, and typically a trend that tons of their peers have adopted also. OCD routines represent an excess of these regular developed psychological routines, or could take on a completely different quality. OCD routines have a later age of onset and are stressful if not performed. They interfere with the child's life and are excessive, checking, washing, and counting. In OCD, as opposed to with regular rituals, indecisiveness and doubt can stop the kid from completing the tasks. Obstinacy could cause unwanted arguments with other children. Rigidity makes the kid unable to easily switch from one task to another as other kids do. Magical thinking, also called thought-action fusion, may be seen in OCD and refers to the belief that if the child thinks something, it will take place. Sometimes this thinking might practically look delusional, and the kid might be misdiagnosed as psychotic. A child with OCD could be extremely controlling, and this need to be in charge can be troublesome for relatives and even for the therapist, as the kid could be oppositional and refuse to do the homework given by the therapist. Parents or caretakers of 10-year-old Brian said, "What an experience for him to go to bed. Brian needs to look under his bed, to fluff his pillows in a specific way from top to bottom only. He opens and closes his bedroom door 2 times to make certain it's closed. He goes to the restroom again to check and see if the faucets are turned off. He ensures that the front door is closed and locked 4 times. He turns the light off and on several times to be sure it's off. He looks out of the window to be sure no one is outside. He checks until he feels that everything is ideal. If he does not do this, he cannot go to sleep. That is being outrageous, and I get frustrated with him. Should I be concerned about my child's superstitions?" No, most kids go through a normal phase in which they act in superstitious ways. A superstition is a belief or concept not based upon reason or knowledge. It could be an irrational or extreme belief in fear or magic. An example would be the following. Kids might not want to walk under a ladder for fear of misfortune, or might hold their breath until they cross the street, which will help them prosper throughout a test at school. That conduct must not be interchanged with OCD. When kids are in this stage, these beliefs are playful and are not really serious. Kids can laugh about them and tell them to other kids. Aside from that, they tend to vanish within weeks or months. In OCD, the fears or rituals are serious to the kid and may not vanish extremely rapidly. As they're shameful, they are not told to others. Superstition and magic beliefs are very common in the child and adult population as a whole. Many people still keep away from walking under ladders or are mildly pretty upset when a black cat crosses their path. There are still high-rise buildings built without a 13th floor. It is regular that a young kid's thought processes include magic thinking and a belief that magic is real. This is the reason that stories like Harry Potter resonate so well with kids and grown-ups. Kids between 6 and 8 years old may trigger their fingers to protect themselves from telling a lie, or may not walk on the cracks in the concrete pathway to stop bad luck. In regular development, superstitious rituals tend to fade by 8 years of age. Tension and efficiency anxiety could produce superstitious behaviors in adolescents and even in adults, that is, carrying a lucky charm. In OCD, these beliefs cross a line and be excessive. Instead of decreasing anxiety, superstitions may now increase anxiety. They become emotionally draining pipes, squandering a ton of time and producing no evident benefit. Although the irregular ideas and habits in OCD have some resemblances to typical superstitions, they're more intense and they come from nowhere at all. Thus, they are qualitatively and quantitatively different. Will my son attack me or someone else? What is the risk of violence in OCD? Intrusive thoughts may involve violent fixations about hurting others or oneself. Ideas of causing harm, like leaping from a bridge, jumping in front of a train, or pushing another person in front of an automobile, aren't uncommon. Patients also describe thinking of, or wishing harm to, a relative, or impulses to shout something violent. Kids might worry that they will act on these ideas, and may ask their parents to lock away the home knives, or they might refuse to leave the house. Fortunately, the possibility of acting on these impulses is low, as children with OCD are tortured by their symptoms and feel guilt and embarrassment. There is danger only if kids have additional emotions or symptoms like intrusive, violent ideas that are not distressing to them or are even pleasant. These feelings are signs that violence could be possible. Additionally, violence is a possible concern if the kid has acted formerly in a violent manner, or hears voices saying to be violent, or if the child is psychotic or feels uncontrollable and alluring anger. If any of these occur, expert help needs to be gotten instantly. Is there a threat for suicide? What should I look for and what should I do? The risk for self-injury or suicide must also be examined, particularly when there's an associated sadness. OCD and desolation might exist side by side in kids. Kids do try to kill themselves. Nevertheless, they regularly don't comprehend what is needed to die. An example would be the following. A child may swallow 2 vitamins in an effort to commit suicide, and the family might rule out this as suicide effort. Kids can't understand that death is permanent and could think they will have the ability to come back to life later. Kids, in some cases, make threats when upset that they don't mean. Still, accidents happen. Know if your child is sad, is not sleeping well, has a bad appetite, is being more withdrawn, or is making declarations like, "I wish I was not here. I wish I could die. I do not like my life. I don't like myself," or "No one likes me." Go instantly to a place where your child can be assessed by a kid psychiatrist. If your kid is already in treatment and is receiving medications, get in touch with a medical professional instantly to talk about the problem and to see if this self-destructive behavior might be a negative impact of the medication or if something else is going on. Do not wait for the next appointment. Risk for suicide is an emergency. As a parent, what should I try to find in our kid? I don't want to miss out on seeing or doing something that will help our child. Acknowledging OCD is typically tough as the child ends up being proficient at hiding the doubtful behaviors. It is not unusual for a child to take part in ritualistic behavior for months and even years before parents know about it. The parents might believe that the peculiar behavior is just a phase, despite the fact that the kid's behavior usually uses up a great deal of time and energy, making it difficult to complete tasks such as homework or chores. He or she will still try to hide it due to shame or guilt. The child may compensate by sleeping less or skipping some activities or getaways so as to complete the routine. There could be serious problems with concentration just because of the invasive thoughts and lack of sleep. In addition to feeling frustrated or guilty for not being able to control his or her own thoughts or actions, the kid with OCD might have low self-esteem in comparing himself or herself to peers. It is common, eventually, for the child to ask his or her parents to take part the ritualistic conduct and to seek frequent reassurance. In the beginning, parents could not understand that these are indicators of OCD. If parents don't participate in the routines, tantrums and tough behaviors develop. The phenomenon in which family members take part in or help with a child's rituals is called family accommodation. It occurs in around 89% of OCD cases and is connected with inefficient family interactions, family distress, and greater OCD symptom seriousness. It was also found out that the presence of comorbid oppositional bold disorder, ODD, and family accommodation was a substantial predictor of poor results. The child's caretakers need to search for these possible signs of OCD. Raw, chapped hands from constant cleaning. High rate of soap or paper towel use. High unexplained water costs due to long showers. Unproductive hours spent apparently doing homework. Holes in school test papers and homework because of writing and eliminating words several times. Requests for family members to repeat weird phrases. A persistent fear of disease. An abrupt increase in laundry as a result of the child asking to clean the exact same clothes repeatedly. Fear of germs. A long time spent getting ready to go to bed. A permanent fear that something dreadful will happen. Consistent monitoring of family members' health. Unwillingness to leave the house at the same time as other relatives in order to perform rituals undetected. Is OCD due to bad parenting? What should we expect as parents of a kid with OCD? Never. The causes of OCD are external to the kid's parents and caretakers. When a child has OCD, the whole family is affected. Parents become confused and confused. This confusion sometimes looks like disappointment and anger. Kids at times have episodes in which they are extremely upset with their parents, specifically if the parents don't allow or are unable to comply with the OCD demands and behavior, such as stopping the child from showering for hours at a time or refusing to wash the child's clothes several times. If parents overreact and attempt to disrupt the behaviors, the child could be hostile or incredibly restless. If parents succumb to the rituals, the kid never ever learns to confront his or her fears. Younger kids who have a difficult time articulating their needs may appear naughty, oppositional, clingy, or anxious and might have long and regular temper tantrums. Parents might be blamed by other family members for being too lax to the kid if they go along with the rituals, or being too strict and not understanding if they refuse. The mother and father could have a different understanding of the situation and of the mindset to take. This difference typically produces tension in the couple. A smart child might then play one parent against the other for his or her own advantage. Having a kid with a chronic illness is difficult to handle, and you will really need all the support you can get, both familial and expert, to achieve positive results. The parents need to be united in order to be firm, supportive, and consistent in their rules for the child and in picking the kid's treatment course. My child with OCD appears to break down only in the home and not at school. How can this happen? If he can control himself there, why can't he do it at home? This is pretty common. Many kids with OCD may succeed academically and with other school activities, but they could have difficulty completing their homework and papers as they concentrate on getting things perfect. Many kids, feeling humiliated by their symptoms, successfully hide them from their peers and teachers, but cannot hide them in the home when they're more worn out and less in control of their habits. They also know that they won't be judged in the same negative manner in the house. Your child ought to be assessed for this issue because it is not clear that he will have the ability to continue to hide his symptoms while at school. The inescapable changes that occur at school, for example, starting in a new school or grade, meeting new children, having more scholastic pressure, might trigger the symptoms to appear in school at a more difficult time. I presume the first check out to the psychiatrist will be very important and may take a lot of time. What will the physician do with my kid on that first visit? At first, there will be a thorough psychiatric evaluation. This assessment usually needs several hours over several office visits for the kid and the parents. With the parents' approval, other substantial people, such as the kid's pediatrician, school personnel, or other loved ones, may be gotten in touch with for added info. The evaluation frequently includes the following: description of the present issues and symptoms, information about health, allergies, surgery, and other diseases and treatments, both physical and psychiatric, including past and present medications, parents and members of the family's health and psychiatric histories to see if there is any genetic or familial component. Kid growth history. Info about school history and school performance. Info about good friends and hobbies. Information about family relationships. Psychiatric interview of the child. If needed, special assessments such as psychological, academic, speech and language evaluations, neural assessments, or X-rays. If medications are considered, blood tests and an electrocardiogram, EKG. Then, the kid's psychiatrist will develop a report describing the child's condition and explain it to you in terms that you and your kid comprehend. This report will include the natural, mental, and social parts of the condition. The developmental needs, weaknesses, and strengths of your child will be included as well. Time will be given to answer questions. The psychiatrist is there to be a partner to support your child and family and to help, not to blame or judge. There's no guilt or fault to be appointed. You and your kid don't need to worry about how you're going to be seen throughout the examination. The psychiatrist will listen to your issues and help to specify a goal to attain. You and your kid should always ask questions if something covered is unclear. The psychiatrist will offer treatment suggestions and describe the benefits and risks of the suggested treatment so you and your child can feel comfortable with your decisions. A specific treatment plan is then developed, talked about, and accepted. Remember that flexibility is the key word here. Treatments will be modified until the best method is found. Apart from this, as your child develops and grows up, the treatment that worked at 8 years of age might not work at age 10 or 12 and will really need to be changed. You should expect and comprehend that changes will occur. Can we take a vacation? We actually need one. Will this hurt our child? Will we miss out on treatment or treatment? Of course you can take a getaway. If your kid is stable and the doctor visits are every couple of months or so, undoubtedly you should take a getaway. You should talk about the trip with your kid's doctor and clarify it clearly to your child beforehand to calm his or her anxieties. In the acute stage, though, if your kid isn't yet steady on treatment or is in a relapse, you may want to discuss with your physician the best way to deal with such a journey. Should I get a second opinion from another psychiatrist? It depends. If you are satisfied with the treatment team you have, and if they're knowledgeable and confident in their technique to your child's problem, then this should be sufficient, particularly if you see development in the treatment and in your kid's conduct. But if you have any doubts or concerns, or if the case is especially complex, you might want to think of another opinion. In this particular case, it could be wise to head to a bigger academic health school or tertiary center that has strong kid and adolescent psychiatry services. As always, this choice is very individual and personal. If you have determined to get another opinion, it is normally a great idea to discuss this with your child's psychiatrist. Even though this matter could be fragile, a really good and extensive psychiatrist will welcome a second opinion to verify his or her conclusions and to possibly add added insight and experience. Your kid's psychiatrist may even have the ability to advise someone at his or her health school or a teacher or mentor. What is the role in the treatment? Members of the family want to help their loved one. They will want to get educated about the disorder and to comprehend its causes and treatment. Sometimes, family members could bring you new information. For example, other cases in the family. They will help you deal with your kid's signs. You could also find that they will help you communicate better with your kid's therapist if it is tough for you. They will be able to work as a team to support you. Family members might be able to report to your child's therapist with your approval any signs that you may have overlooked or that don't take place in your presence. They could also help you by easing you of certain tasks sometimes, like helping with your child's homework or with the other children. Obviously, you should use discretion if you have certain family members who aren't understanding or happy to help. There are several things you should tell your family members. Understand that OCD is an illness and that your child is not responsible for all the signs. Ask relatives not to criticize or make negative comments, but rather to be calm and supportive. Let them know that even if they try to be handy, your kid might not be willing to get their help. They must try to be kind and patient and not take any of your kid's comments personally. Do not tell your kid to stop the compulsive behavior, as it might make her or him feel worse. Rather, use appreciation when seeing that your kid is making an effort to stop the conduct. Manage expectations, keep away from expecting way too much or insufficient, and don't push too hard. Focus on the positive. Learn treatment strategies from the therapist. Members of the family can try to follow the child's homework so they can help if the kid allows it. But remember that a teen might not want to be coached. Look out to problems possibly because of the treatment. Do not associate everything that fails to OCD. A bad day might be just a bad day. Treat your kid usually when he or she recovers. Look out to any indication of regression. Encourage the child to stick with the treatment and be sincere and open with the therapist. Members of the family might visit the therapist with your child if there is something they want to share or report. Members of the family should set consistent limitations and let your child know what's expected. They should not be too lax since your kid has a health problem. Work with the school and the teachers as necessary. Do not think twice to think about support system for families. Take a bit of time for yourself to get refreshed so that you can better provide support later. Should I try to get the remainder of the family to help in the treatment of my child? What should I tell them? Yeah, most certainly. Family participation and support is crucial. The family needs to work as a group in the battle against OCD. Education of all relatives is needed and acceptance of the child as he or she is. With education, your family can help maintain the structure and discipline that are so crucial in preventing your kid's OCD from needlessly disrupting family life. Structure. All kids really need structure and a day-to-day regimen that makes them feel safe and secure. OCD signs are more serious when there are life changes. Set clear rules and expectations for the child. Give the rules in a positive way. For example, you may say, "Do your homework before watching TV," instead of, "No television until your homework is done." Structure and schedule activities for each day. I have family supper, homework, and bedtime at the exact same time most days. If a significant change happens, help your kid to accept it. Nobody likes change, and definitely not a child with OCD. This has been OCD, Questions and Answers about Common Symptoms and Treatments, written by Sid Van Roy. Narrated by Doug Green.